Good morning. We are now live, so good morning and welcome to everyone. It is now 10 o'clock on Tuesday, not Monday, Tuesday the 15th of March 2022. Welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind committee that this morning's meeting is being recorded. And for those people who want to watch back today's session, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber in person, and there is a variety of in-person and virtual attendees as our guests this morning. Can I thank our guests for the input to date and the papers that have been submitted? And can I ask presenters to restrict their opening comments to 10 minutes, please? We're going to be tight on time today, so the more we can use that 10 minutes and stick to it, I'd be grateful, please, so that we can use every minute for available scrutiny and evidence gathering. And second of all, can we focus in on tangible outcomes for the residents of Staffordshire? Before we start, just in advance of going through the agenda this morning, just want to make 2 points. Within the agenda, there is the item on Wally's Quarry. This has been debated a number of times at committee in the 27th of July last year and again in October. And I'd ask members to consider what actions, if we feel progress has not been made to date, what actions we are going to recommend or take that will actually improve the outcome for the residents of Staffordshire. So I'd ask you just to bear that in mind in terms of the questioning. And second of all, in terms of the KPIs and the agenda item on that, I'd ask members just to consider one of the key issues post-COVID in terms of recovery is how we recover that position in terms of delays in appointments, delays in operations, and how we are happy that we have scrutinised the effectiveness of local plans, not the national plans, but the local plans to make sure they are as effective as possible as we come out of the pandemic. So let's move on to the agenda with everyone's permission. First of all, apologies.
Thank you, Chair. Apologies from Councillors Janet Johnson, Charlotte Atkins, Rosie Claymore and Ian Wilkes. And we welcome Julie Cooper as substitute for Ian Wilkes at Newcastle.
Thank you, Julie. You're always welcome, so nice to see you. And I note, did you mention the Environment Agency?
Apologies, Chair. Yes, we've also had apologies from Mark Leader, the Environmental Agency.
I'll just make a comment in passing that we did invite the Environment Agency for the Wally's Quarry discussion as a key partner to the solution going forward. We invited them no less than 3 times, and I'm disappointed to say they were not able to provide a representative for this morning's meeting, and members should make their own mind up in terms of why that is the case. They have, however, offered to respond in writing to any questions that we so ask of them, which doesn't allow us that dynamic interface. But members will be aware that we do not have the statutory power to insist that our partners outside of health attend this meeting. Let's move on if we can. So let's move on to item 2, declarations of interest. Do we have any declarations of interest relevant to this morning's agenda, please? Councillor Anne Edgeler.
Good morning, everyone, and thank you, Chairman. Yes, declaring an interest partner governor for the MPFT as the County Council rep.
Thank you. Can I just confirm for the minutes that we are quorate, please?
Yes, Chair.
Thank you. There's always an opportunity to catch people out, it's fine. Particularly when you aren't expecting it, it's brilliant. Item number 3, minutes of the meeting from Monday the 31st of January. Can I ask if the minutes are a true and accurate record of our meeting on Monday the 31st of January for those of you who were there? I'm seeing plenty of nods, so they are approved. I'm reliably informed that all actions have been followed up and all information received to date has been circulated. Equally, are there any matters arising that are not on today's agenda from anyone's perspective? Not seeing any notices of that. So on that basis, let's move into item number 4, which is Wally's Quarry landfill site health implications. Just a re-in-line that it is health implications that we are interested in this morning, and nothing outside of that, please. So let me hand over to a variety of representatives from the new agency, UK Health Security Agency. Who's leading from that side?
Thank you, Chair. It's Alec Dobney from UKHS.
Good morning and welcome.
Good morning. Thank you, Chair, and thank you once again for the invitation to the committee to bring and present to you our latest health risk assessment for Wally's Quarry. If that's okay, Chair, I will share my screen. I've got a few slides just to present.
Thank you. We have them, thank you.
That's lovely, thank you. Thanks for that confirmation. So, yes, this morning I have with me myself, Alec Dobney, one of the heads of units for UKHSA. Katie Spence is the local deputy director. Britta is from our TOX team, and Emma is one of our consultants. So this continues to be a complex and long-running incident for UKHSA. And what I want to do this morning is just present a number of slides which are based around the UKHSA risk assessment that we continue to do each month. Each of those risk assessments is not a single standalone risk assessment. It considers the air quality data and the health data going back right from the inception of this incident. So just to set the scene for this, you can see in the top left-hand corner of this slide the positions of the mobile monitoring facilities that the Environment Agency have got set around the site. I'm sure most of you will be aware of, but just to confirm, MMF1 is in the area of the cemetery, MMF2 is on Silverdale Lane, and MMF6 is located at the fire station, and MMF9, which is the monitor where we've seen the highest concentrations, is embedded within the Gallingale View local population. And just a number of charts and tables here just to highlight the data as it stands at the moment. So we've seen from the beginning of this incident back in March 2021 significant concentrations of hydrogen sulfide. I'm only looking at hydrogen sulfide today. The monitors do a range of different pollutants, but they're all within the normal health-based guideline values and standards. But for hydrogen sulfide, we saw back in 2021 high concentrations of hydrogen sulfide, which then began to improve over the year. Towards the end of the year, October, November, came down quite significantly. And towards December, we were all anticipating that the interventions that took place on site were having a positive effect, and concentrations were reducing significantly to the point where hopefully we could get into the new year where concentrations were below what we have now set as lifetime exposure values. And I'll talk about those in a second. You can see that downward trend. However, in January, we saw an increase of the monthly value up to just above 11 micrograms per cubic metre for MMF9, which is, as I've mentioned, the Gallingale View area. And that's concerned us that some of the interventions on site might not be having that continued positive effect. The other thing to note from this slide is that the concentrations above 7 micrograms per cubic metre, this cumulative percentage time, for MMF9 in the Gallingale area is still 16%, significant periods of time where there is odour nuisance. So this 7 micrograms has been set by the World Health Organization to be anything above that is likely to give significant concern for odour nuisance and for odour complaints. And we can see that for nearly 20% of the time since the inception of this incident, that's continued to be be the case, and we are concerned both for the toxicological impact on people's physical health, but also the odour nuisance, which still seems to be a significant concern. So just drilling into some of this data in more detail, there are some positive bits of news that MMF1 and MMF2 concentrations, so this was the Cemetery and Silverdale Lane, the concentrations of these MMF monitors have been below the long-term lifetime exposure value since June and July 2021. And from the beginning of 2022, the UK HSA is only going to be comparing against the lifetime exposure value now. We had an interim health standard that we used for 1 year back in 2021. We're no longer going to be using that. That's come past. We're now solely using the lifetime concentration value as the measure that we're comparing for health. So just moving on, MMF6 concentrations, this is the fire station. These have been below the long-term lifetime health-based guideline values of 2 since July. However, in January, we just showed a slight exceedance of the value. And again, at MMF9, the concentrations in January remain above this value, and they have remained above this value for the whole of this incident so far. So just in summary of the health risk assessments, which I know most people have had and hopefully have had a chance to read in full, hydrogen sulfide and rectified data up to the end of January 2022 still shows continuing exposure to the population around the site, which includes the Glenkelview. Currently, any risk to long-term lifetime physical health we deem to still be low, still be small. However, we cannot say and we cannot exclude a risk to long-term health should the concentrations still be above that 2 micrograms per cubic metre. And of course, the lower the concentrations become, the smaller the risk to that population will be. So our summary is that we continue to strongly recommend that all appropriate measures are taken to reduce the off-site odours. That's the odours that are above that 7 micrograms that lead to significant complaints around the landfill site, and that interventions are brought into place to reduce both the odours and the toxicological concentrations from the hydrogen sulfide to this area as soon as possible. And I say we'll continue to risk assess against those lifetime values. And that's the end of my presentation, Chair. We're happy to take any questions.
Thank you, that's helpful. I'd just make one comment, which is between the sound system this end and the sound system your end, it's problematic hearing everything. So if you did have a headset, that might be helpful, just to help for clarity purposes.
Okay, thanks, Joe. I'll see if I can do that.
Okay, thank you. I'm going to open up the floor to questioning, but before I do so, I'm just going to make one point, which is I thought the quality of the assessment and the data in the report was really helpful in terms of hopefully informing and leading today's conversation. So thank you for the work that's gone into that and the relevant charts and tables. I think that was clear. So I'm going to open up the floor to questioning. Janice, good morning.
Good morning, Chair. Thank you very much. Couple of questions, and I agree with the quality of the information, actually, and fully support each of that. Just wanted to clarify, when we start looking at the new data recording, that we're still going to be having a consistent method of being able to draw out comparisons and any trends. So the way that the data is being recorded now, we can still look back on all of the other data that's been collected so far and have a consistent output from that. If you could just give us some clarity, please. That's my first question.
Yeah, yes, absolutely. We have got confirmation from the Environment Agency that the monitoring facilities will continue now to be in place in the local area until the end of December 2022. So we will continue to be able to look at all of the data that's provided by those monitoring facilities and interpret that data for the next full year.
Did you want to come back?
Yeah, please, yeah. Thank you for that clarification. The other part, and certainly from when I went up to Newcastle and was part of the meeting that we had originally, and also had opportunity to go and visit MMF9, so the particular one that is located within the housing development, one of the things that I'm trying to focus on here is the fact that it is purely about the health of the impact of those people who live in that area. And while we can still see that those recordings are above the levels that are expected there to be, I would have anticipated a little bit more information as well about the psychological impact of that, the fact that that is still recognised, and how that must be having a profound impact on the mental well-being of those people who live directly in that area. And as having visited there, you can see, you know, you're literally yards away. You can walk across to it from a lot of people's homes. Previously, we've had information to do with the work that was taking place with the local doctors and GP surgeries that would be able to give us some sort of quantifiable information on that. But again, it's just looking at some of that information that maybe isn't included directly, but if we're just being cognizant of that as well. Thank you.
Yeah, thank you. And absolutely, yes. So my colleague Katie Spence and Emma Sandbach are on the call as well. And they've been looking at some work around those broader health implications. So we are recognising that. And not necessarily in the risk assessment based on the air quality data, but there's certainly things that UKHSA have been involved with, along with Richard Harling, the Director of Public Health.
Finished, Janice? Keith.
Thank you, Chair. Good morning. Yeah, I can remember the meeting we had over in Newcastle. I can remember visiting the site and going round with yourself, Jeremy, and others, you know, on the day, and seeing all the different disruption that occurs there, which is quite significant without the smell. I'm very, very much in favour of this continued monitoring. I think that's something that this committee insisted upon last time we discussed this, so I'm very glad to see that that information is now coming back. I still don't think necessarily it goes back far enough. I completely agree with my previous speaker for actually, you know, the fact is that we can't compare even to January and February last year at the moment in these figures. We can only go back to March 2021, which slightly concerns me because obviously there's some seasonality involved in what goes on. Being a chemist from my past, shall we say, I'm glad to see that many of the other gases and materials that are in the air, shall we say, those that are far more carcinogenic and everything else seem to be quite low levels at the moment. But my concern is that MM9 is the monitor that's in the middle of these houses. It is the location, particularly in January, which has only just gone, where everything seems to be going south, shall we say, or getting a lot worse. Now, whether that's seasonal or not, I don't know. It could well be, because we don't have those figures in February and March and January back in 2021, or even in fact the year before, when there was obviously monitoring happening somewhere on the site, even if they were just spot inspections. I'm concerned that really these figures don't prove, in my opinion, that the work that's been going on has been all that successful. Now, obviously, we probably need to have more figures, and I would have liked to have known if you got the February figures, whether you've got them or not. But I do think it's something that we'll have to keep monitoring if this is going to be the output and the information that's being gathered. And I'm also concerned that you have just stated that the monitoring will only go to December this year. If we still haven't even got a full year's monitoring system, how can we see what the seasonality has, and therefore what impact are the moves to reduce this hazard from the local residents and from the local community, and how successful those actions have been, considering the increase in January? I'll stop at that point and see what the gentleman says.
Alec, before you answer that, can I ask you very specifically to pick up the comment that was made by Councillor Flunder that the work that's gone on to date hasn't been that successful, and then pick up the other points that he made after that, please.
Yeah, yes, thanks, councillors. It's very difficult for me to say whether work on site has been successful or not. Where, you know, the UKHSA, we're not the experts in the landfill site, and I think that is clearly a question for the Environment Agency to respond to. We are obviously aware of the interventions, many of the interventions that take place on site, and the only way in which we can determine whether they've been successful or not is whether or not the concentrations outside of the perimeter of the site continue to fall. That's our measure. That's the data that we interpret is the data that we see. And so therefore, we can, there's a direct comparison between an intervention that prevents hydrogen sulfide coming off the site to what we see at the monitors, and then how we can interpret that data. So I do feel that that's really a question for the Environment Agency to pick up. Obviously, we've seen improvements in hydrogen sulfide concentrations reducing last year. We are aware that there are some seasonal effects to whether hydrogen sulfide sometimes comes off site. We've seen that. We've been able to, within the scientific advisory group, we've been able to determine certain parameters within the Met conditions, so low and high pressure, low wind speed, low temperature, does give rise to periods where there may be more hydrogen sulfide emitted from the site. But a well-contained landfill site, even in those conditions, shouldn't necessarily give rise to significant concentrations of hydrogen sulfide. So there are lots of complexities around this site. But I say for us, it's about looking at what concentrations come off the site, and it's for the Environment Agency to determine the effectiveness of those interventions. As far as the data is concerned, I completely agree. We haven't got data that goes back to January, February 2021. So we can't interpret the data that we don't have. However, we can consider the fact that there were significant complaints during February and early March. And it would seem sensible that if complaints were, say, significant at that time, then concentrations were likely to be the case. And that's why we implemented the intermediate value that we used last year, which was the ATSDR value, which looked at a year's data, 14 days to 365 days. And we considered that from the beginning of January right through to the end of December 2021. So we use that measure as to compare against health criteria. However, that is a year value, and we considered it even though we hadn't got data prior to March. Going forward this year, we continue to recognise that we have got a data set that goes back to March. We'll continue to interpret that data into this year. And as I've mentioned before, the monitoring stations will be there and through until December 2022. So we will have more than a year's worth of data to compare to when we get to March, April this year. Thank you, Chair.
Keith.
Thank you, Chair. Didn't really answer my question about the time of monitoring. My concern at the moment was the fact that the increase is in January, and we're going to be leaving the site, or you're going to be stopping the monitoring process potentially in December. My fear is that the peak of the gas emissions could well be over that early winter period, or midwinter period into early spring. And without that having at least 2 years' worth of values, how are we going to be able to estimate or even evaluate the work that's being done on site by the Environment Agency themselves? I realise that you're contracted to the Environment Agency, therefore you can't really speak out or anything else. But I would very much like your own personal opinion about your concern about that increase from up to 32, which is almost back to the original values of some of the peaks that were earlier in 2021, where there was massive amounts of issues around people complaining and everything else. Are you personally concerned about that sharp spike and the increase in all the complaints now?
I should just make the point that the UK HSA, which was Public Health England, is independent of the Environment Agency, and their role here is to provide the monitoring and the data and the assurance on health, rather than contracted to the Environment Agency. But Alec, do you want to pick up the other salient point in terms of your personal view?
Yes, thank you, Chair. Well, we're going to see, and just to reiterate that the Environment Agency is responsible for monitoring outside of this site. If there is still concern that the concentrations are still significant, and whether or not they continue to monitor after December 2022 will no doubt still be, something to consider as the year continues and concentrations come in. We will have this winter's period from December through to March in the next few weeks to see what the winter period has provided. So we'll have some idea of met conditions and winter pressures on the landfill site. So we'll have something to look back over this January, February, March, as the weeks and months go ahead. But I think it's the Environment Agency's responsibility to monitor. It's their decision to monitor. We will continue to put pressure on the Environment Agency if we feel that towards the end of this year we haven't got sufficient data to consider the further risks that could continue to be approached to us if that's the case.
Thank you. Julie.
Thank you very much, Mr. Chair. I'm Councillor Julie Cooper. I'm Vice Chair of the Newcastle Borough Council and Vice Chair of Health Scrutiny. Wally's Quarry, as you know, is top of our list. I'm glad you're satisfied with the monitoring, and I know you're nothing to do with the Environmental Agency. I do appreciate that. So I'm very satisfied. But when you say you're satisfied with the monitoring that you've got, I'm more interested in the water supply as well, because we're only doing the odour. Now, could the water and any minerals going into the water supply add to the smell? That is a question I'd like answered. We're not satisfied in Newcastle. In fact, we're very strong against the Environment Agency. We don't think they're doing anything at all. In fact, we don't think they're fit for purpose. So when you keep quoting them, you know, to us, it's neither use nor ornament. And I think what we really want is to close the quarry as soon as possible. So what we could do is the backing from everyone else to actually help to do that. That's the only thing that will satisfy the residents of Newcastle Borough. Thank you.
Can you pick up the question parts, not the statement parts of that, please, Alec?
Yes, thank you, Chair. Thank you, Councillor. In regard to water, again, it's the Environment Agency that are responsible for monitoring any water or leachate that comes off the site. And if there's any concern that that could have an impact on the wider public, they would have to make us aware of that. To date, I'm not aware of any impact on surface water or water that's leached out from the site that has given grounds to that. But if that was the case, they have a duty to inform us about that, and we would risk assess that along with the air quality.
Yeah, more important than that, I'm thinking of the water that then seeps through into the soil, which then seeps down into the watercourse. We are satisfied with the smell, you are satisfied with the smell, but nobody to our depth in the Newcastle Borough has actually gone through that. We haven't actually seen the response of what can be seeping through the water course, because everything seeps through eventually down there. And I might not be here, you might not be here, but for our generations to come, they will be here, and that will affect them. So it's not only the fact that we're satisfied with the smell, we've got a bigger problem that nobody's addressed yet, and I'd like addressed.
Can I just come in? I think Alec was clear in that it's the Environment Agency you need to make the referral to. So I think I'm just going to move on from that, if I can, please, because I think that line of questioning has been answered. Thomas.
Yeah, thank you. Sorry if I missed it on an earlier slide, but I didn't see it. When we've looked at this before, we've looked at qualitative data from residents. So we've had what symptoms they've had and what they're feeling. It seems we're looking at air monitoring today, but what about what the residents are feeling? Because arguably that's more important than just the air monitoring.
Yes, sorry.
I was going to say, Rich, you might want to at some stage bring Richard Harling in at some stage, but that's your call.
Yeah, thank you, Chair. Yeah, I'm happy to do that. Either Richard or Emma would like to answer that question. Thank you.
Chair, if I can just reflect on the question. So I think it was about understanding what residents think about the situation. I think we know very well what residents think about the situation. I think they're extremely unhappy with it, and I think they're extremely frustrated that we continue to have foul odour and excess levels of hydrogen sulfide 15 months on, despite all of the attention that's been given to the site. I'm not sure we need very much more monitoring to understand that. I think we understand it very well. Thank you.
Thank you for the clarity of that answer. Thomas, do you want to follow anything up there in terms of...
Yeah, if I can. So it's not what they're thinking, it's what they're feeling. So before they were having headaches and symptoms and all sorts of things that we listed out before. Is that still being monitored, or is it just, it's like when you go to the doctor, right? You have blood results and your symptoms. We've got the blood results, we've got the air monitoring, great, but what about what people are actually physically feeling?
I think it's a good point, which is what is the outcome and how do we resolve this issue. Next time you speak, can you just speak into the microphone? It's just a bit clearer for those people on loops and things.
So, Chair, again, I think the question is whether residents are still experiencing symptoms. So I think, again, we do know that residents continue to report a range of problems, both the foul odour, symptoms associated with that, such as headache, nausea and sleeplessness, as well as respiratory symptoms, such as irritation of the eyes, nose and throat. And those symptoms correlate with the hydrogen sulfide levels. In other words, they seem to be worse at points where hydrogen sulfide levels are highest. We do still give residents the opportunity to report those symptoms. They aren't reporting them in high numbers, but one of the reasons for that may be because I guess if you're a local resident, it's not obvious that there's any action being taken as a result of that. So things are being done, but there is not as yet a clear point of resolution for local residents that I think they can be confident in.
Thank you, Richard, for that clarity. Can I move on, Thomas? Anne Edgener.
Thank you very much, Chairman. Good morning, everyone. I think, we sit here as councillors and we're representing the people in Staffordshire. And more importantly, on this, we're representing the people in Newcastle. And I think these people have suffered long enough. We're not talking about a few months. We're talking about years now. And these people are still suffering. And for all the monitoring in the world, when are we going to see an end to this problem? Looking forward, when are we going to see some sort of conclusion to satisfy the people in Newcastle so they're not suffering long term? So I'd like to see some end to this problem and to, so that the people living in Newcastle can see some forward planning as to how this will come to a conclusion, an end, so these people don't have to suffer any longer. And can I also mention, Chairman, we're talking about the Environmental Agency. Well, I'm actually, as a councillor, and I think I speak for everybody in this council chamber, when I say we're disgusted that they're not even coming along to speak to us and sending a representative. I know we've no statutory powers, but I think we should be sending a strong letter to government, submit it in government, to make them realise, that we're being ignored virtually. So I'd like your comments on that, please. Thank you.
Just 2 points, Richard, before you answer. The first one is obviously the effect isn't just being felt on Newcastle residents. There are residents across in Stoke and top end of Stafford Borough. So that's the first point I'd make. And the second point is, Richard, I wouldn't expect you to comment on the Environment Agency not attending. That's probably an issue for committee, which we'll take at the end of this session. Thank you, Richard.
Yes, thank you, Chairman. Just to reflect on the situation overall. So I think back in the autumn of 2021, we were reasonably optimistic that there was a clear improving trend. I don't think we are confident in that anymore. We've seen a spike over December and January. There is ongoing work on the site, but there is not as yet, to my knowledge, a clear plan that gives a confidence and a date for resolution of this situation. And I think that is of concern in terms of the health risks, both the direct health risks from the hydrogen sulfide gas, but also the ongoing mental health issues that it is causing and the general stress on the local population. And the longer the situation endures, I think the greater our concern. Thank you.
Really helpful. Thank you, Richard. Are you happy with that, Anne?
Thank you, Chairman, and thank you, Richard, for that. I'll be happy when we get some sort of conclusion on this Wallis Quarry, because, as I say, I think the residents have suffered long enough and they need some sort of action that we can look forward to. Thank you.
So before I bring in Janice, can I just follow up that line of questioning, please, Richard? You talk about a lack of clarity of direction in terms of being able to assure residents of what was promised them, which I think at the time last year in Parliament was alpine fresh air. What would be your suggested route forwards to deliver on that commitment from government? Is this about the Environment Agency redoubling every effort because there is a clear route forward, or is this an extreme case whereby a different plan of attack needs to be taken?
So thank you, Chair. So I think on behalf of local residents, we need to be lobbying for a decisive and urgent solution to the current problem. I think if the regulatory framework does not allow that, we should be asking that government takes a more direct involvement and does something to bring this to a satisfactory conclusion as quickly as possible. I wonder whether we should be asking that question at the very highest levels of government in order to encourage them to take the necessary action. Thank you.
And just following that through before I bring in Janice, and I will bring in Janice, just following that through, presumably the only decisive action, given that this is an extreme case of hydrogen sulfide escape, is to discontinue further operations.
I think in the absence of a clear plan that gives confidence and a timescale for resolution of this situation, the only thing that I can think of is to bring forward closure of the site. So I understand it is due to close in any case in 2026, I believe, and bringing that forward, I think, would give us greater confidence that emissions were going to be brought under control. I think also it might send a clear signal to local residents that government was in fact taking this situation seriously. Thank you.
Thank you for the clarity on that. That is very helpful. Janice.
Thank you very much. Yeah, I was going to carry on. I fully support what my colleague has also suggested there. There's two parts that are intrinsically linked, and the absence of the Environment Agency today helps us to keep a focus on the health. And my question is to do with how we're supporting the residents now, physically and also mentally. And if some of the commitments that were made when we were up in Newcastle are still being offered to the residents to support them. Do we have any idea of what cost that has actually introduced, not of our doing, to the area as well? And then just to make sure that the message is coming across loud and clear that we can't be asking these questions again. It's nearly probably a year since we had that meeting and we were asking those questions, having those reassurances that aren't there. So the immediate one is, are those residents still being supported in their health and mental well-being? And secondly, my support is unequivocal to making sure that we're not doing this again anytime soon, that there is a resolution. Thank you.
So, Chair, the NHS has set up a dedicated mental health service to try and support local residents. I don't have the data on usage, but I understand that it hasn't been hugely used. But nevertheless, I understand they will continue to make that available. And then, of course, all the normal support through local GPs and local health services is available to those residents, as it should be to anybody else. I think what residents are really looking for is a resolution to the situation. The one thing that will allay their anxiety, stop them from suffering symptoms and give them some comfort is when that site stops smelling and releasing hydrogen sulfide, and when they can be confident that they're not going to get a recurrence of the situation that we've been seeing over the last 15 months.
Thank you for that clarity. Last two speakers on this, and then we'll move to a resolution if we can, please. David first, and then Richard.
Thank you, Chair. I know nothing about fumes escaping from waste tips, but if we were to close, if the place were to be closed, what would have to be done to stop the pollution escaping? I guess that the pollution, air quality is being harmed by what's already in the ground, And my guess is that it would be years for that to become safe. So what would have to be done to make that place fit for purpose or safe for the neighbours following or before closure?
Chair, I think we would probably need to take expert advice from environmental scientists who would be able to provide a much more detailed and confident explanation than I think I could give on this occasion. But again, I think it would be part of any government action to make sure that whatever is done to remediate the site, we could be confident that it is going to control emissions long into the future.
Thank you, Richard. Richard, last speaker.
Thank you, Chairman. I'll be brief in terms of the conclusions that are in the paper here. And I do thank for the report and the information that's before us. But the conclusions are obviously there before us. They clearly state that the areas where they're low, and then there's areas of high and concern. But obviously the conclusion leads to the recommendation of just continual monitoring, and I think that's where the committee has a problem. So I'm heartened to hear what Richard Harling has said, because I support where we go with that wholeheartedly. And it is disappointing, as already alluded to, that the Environment Agency aren't here. But at some point, somebody's got to not necessarily beat them over with a stick, but we've got to really ask some serious questions. Thank you, Chairman.
I didn't hear a question in there, so I'm gonna move to. Thank you. Very kind of you to do my summary for me, and. Don't think that. Don't think I'll pay you for it. It's but thank you. Can I just move committee towards a conclusion on this piece? First of all, thank you to Richard, Dr. Richard Harling, and to Alec for what has been a really useful summary and assessment of what is an ongoing story that hasn't been brought to a successful conclusion as yet. I do note, however, in passing that the UK HSA is very clear that the levels of benzene, toluene and the other substances as part of the conclusion within this report are not areas that that you are concerned about. So I think we ought to just make that note. The area that is of concern is related to hydrogen sulfide, but equally that this has been an ongoing issue that has been rumbling for certainly since late 2020, and despite the best endeavours of everyone around the table, plus the Environment Agency, who isn't around this table today, and I'm very disappointed that they've chosen not to attend, that this issue doesn't have a resolution. I note the comment which is we cannot exclude the risk to long-term health, which I think is an important one, and I note the comments in the Chamber about mental health and the impact of not necessarily having a conclusion or timelines to be able to get to a conclusion for those residents who are experiencing the extreme fumes in that area, particularly as there has been a backward progress over recent months. I also note that there is no clarity on the direction of travel to be able to get to a conclusion. And as a result, I'm going to make two recommendations. One is that we write to the government minister who looks after the Environment Agency and just make note that they chose not to attend committee today, and that is disappointing because we weren't able to question them on the specifics about the plan. And the second thing I'm going to suggest is that instead that as well we write to the Prime Minister and ask for his urgent intervention with the recommendation that they actively look at what can be achieved by cessation of activities on that site and capping fully that site to ensure that residents can get what was promised of them last summer by the Prime Minister. So that is the two proposals I have that I'd like to make. Anne Edgeler.
Thank you, Chairman. I totally agree with what you're saying, but at the same time, if this is supposed to be closing in 2026, why don't we ask the government to move it forward and close it now? Thank you.
I think that was my suggestion, that we close it. We asked the government to intervene with the view of closing it with immediate effect. That was, sorry, I wasn't clear enough, but that was my suggestion. Debs, have you got a form of words that came from that is clear for members to vote on? Just while you're looking at that, Julie Cooper.
Very much, Chair. Thank you very much for everything you've all said, and thank you very much, Anne, for everything you've said as well, and in the chamber. What I'd like to say is this has been going on for donkey's years now, well, since 2006, as I know, but with everybody having COVID in 20, and we were all stuck in our houses.
Does this relate to the two resolutions?
I'm just working my way up to that one.
Yeah, okay, quickly.
This is why 2020 we were all stuck in homes, we couldn't go out, and this is what's brought it in. That's why the Environmental Agency came in. Until then, they weren't in the mix. So it has gone on for years. As I've said, my resolution is because of the poly...
No, there's a resolution on the table. Can you talk to the resolution,
what we're doing
please?
is the poly thing that they're using now is not working anymore. So what they're going to use to cap it with... Can we have it capped as soon as possible?
No, I'm sorry. You are not talking to the resolution that's on the table. Could you talk to the specific resolution on the table, please?
Okay. I'd like to see it capped as soon as possible. If it's closing in 2006, why can't we bring it forward?
Okay. We will carry on with the two original resolutions on the table. One was to write to the environment. It was to write to the government minister. Debs, can you just put a form of words that everyone can understand?
Yeah, I will formalise these, but the intention is write to the government minister for the environment to state disappointment of the Environment Agency not attending the meeting today, to respond to questions and concerns of this committee on behalf of the residents of Staffordshire in relation to Wally's Quarry. And the second resolution would be to write to the Prime Minister to ask for urgent intervention and to look at what measures can be taken for the cessation and capping of the site and to close it immediately if possible. I will reword those, Chair, but I think you've got the intention.
We'll take away the words if possible. Can we vote on that, please, Keith, unless there is something salient you think is missing?
My concern as well is that, although you turned around and said that the other materials that they're monitoring are below requirement for health and reasons, I'm afraid when I looked at the ethobenzene, the toluene and the xylene levels, they were in fact increasing at an exponential rate in January as well. And so I am also concerned myself personally about any other materials that might be riding on the back of the hydrogen sulfide that will be then potentially having other hazards as well as just the hydrogen sulfide.
Can I just play devil's advocate? If the site is closed and it is capped, surely that covers your...
I'm talking about the next 8 or so months when the monitoring is continuing until December.
I think the intention is to ask government to act with immediate effect. I think that is our request of government. Yep. I think there was significant concern around this chamber that we can monitor to a week on Christmas.
I understand
and we actually need to do something about the health impacts to residents. So
it was your statement saying there was no risk from these other elements that I disagreed with. That was all.
Okay. I just read what was in the report in front of me. Okay. Thank you. This one's more difficult than it... I will try and not bring my spade next time and start digging. So we have two resolutions in front of us. The first one relates to the Environment Agency. Shall we vote on that one first? Are we prepared to write to the Environment Agency? I'm seeing everyone. Thank you. I'm sure that Debs will do it to reflect the mood of the meeting, even if I haven't controlled the mood of the meeting. So let's move on to the second resolution, notwithstanding the interventions that have been made around the chamber today. The resolution is to write to the Prime Minister to ask for the immediate cessation of activities on the site. Are we in favour of that? Well, I think that is unanimous. I think we can call a halt to the Wally's Quarry discussion. I'm going to suggest that we don't diarise when to bring this back, and that as soon as we have any responses from government on those 2 letters, that we circulate that around members independently. If we've seen nothing further, that we bring it back in maybe 2 months, because this is clearly an ongoing issue without clear resolution that the committee are happy with. Are we happy with that as an approach? Okay, I see plenty of nods around the chamber. So on that basis, I think we can close item number 4. I would just like to thank all of our contributors, UKHSA, plus Dr. Richard Harling, for your reports, for your information, and for guiding us through what is clearly a very difficult issue for many residents in that Newcastle, Stafford and Stoke area who are being badly affected. So thank you. Item number 5. So this is the Transformation Programme update, and I believe, Marcus, you are leading away with this, but I also am aware that you are leaving us in 10 minutes to come back again, I believe.
Thank you, Chair. I've rearranged my diary, so the meeting after this at 11, I've apologised for, so I can stay for this item and the next item, if that's okay. Helen and Jenny are with me to actually do the presentation and run through the highlights in the paper. But I think, Chair, we picking up on the conversation we had on Thursday, we felt it might be worth me just providing a brief update on the Cannock MRU, which, whilst it's not specifically mentioned in the papers, is obviously an issue of concern, and we have picked this up in previous meetings. So if it's okay with you, Chair, I'll just say a couple of words on the Cannock issue, and then I'll hand over to Helen and Jenny. They can run through the slides, and then we'll obviously pick up any questions at the end. So,
sorry, Marcus, I would welcome a comment on the Cannock MIU. I'm aware of a petition that was presented at Council no more than about 5 weeks ago, which demonstrated the local feeling on that. Can I just bring in Councillor Phil Hewitt, who has left other meetings to be with us?
Thank you. And hello, Marcus, how are you? I'll take
Very well,
away.
thank you.
Thank you. Yeah, this has been something that we've been campaigning on for 2 years. It's quite important, and I'll give you some background to it. The MRU unit was very valuable to the people of Cannock Chase, and I believe well used by the people of Cannock Chase, and well loved, and certainly by me on numerous occasions as well. So it closed down pre-COVID, or it closed down as COVID broke. It was the right thing to do. There was no objection whatsoever from members of Cannock Chase because we was aware that the resource had to be moved, and that was fine. The problem is that go on a number of months or a number of years we're into now, and there's been absolutely no input or no. There's no indication that we'll open at all, and that's a real concern to us. We have emails and such to say yes, it will open in August, open in September, and for want of a better word, it looks as though we're either kicking it into long grass or kicking it right down the football pitch. We never seem to actually simply get it open, even though we get lots of promises. Now, some of the background to this, if the chair will indulge me, is, for instance, I broke my leg. As always, when you break something, you think it's no more than a strain, and off I go to Lichfield MRU unit, who were absolutely excellent. But the challenge from then on is I then end up in Burton Hospital. I then end up in Burton Hospital for physiotherapy. Burton eventually moved me to Cannock. But that was fine for me because I have a wife who can drive me. I have family who can take me when I can't go. But then, exactly the same time, I have a constituent who broke her arm. So she then went to Lichfield MRU and then got referred to Burton, and she hadn't got the same resource. She hadn't got the same resource at all to continue with their treatment with the same profile of hospitals. So you look at that, that's a real issue for us. Little things like, you know, a little wicklow, for want of a better word, to get into medical, where you can go to an MRU unit with something that's incredibly painful but incredibly simple to solve for somebody with medical skills. So now we have a choice between going with minor things to Wolverhampton, to Stafford, the Lichfield MI unit. If any of my constituents says, where would I go? I'd say go to Wolverhampton and Stafford. So one, it's putting cars on the road, which is not right. Two, we're filling up A&E units, which we shouldn't do. And three, I genuinely think that the people of Cannock Chase deserve an MIU unit. I don't understand why everybody else within the Staffordshire area, I believe, has opened and ours hasn't. I don't think it's a financial one, but I would like to see a real effort to get it open again, Marcus. Thank you. Thank you, Mr. Chairman.
Thank you. Over to you, Marcus.
Thank you, Chair. So the CCGs are fully committed to reopening the MRU. As Councillor Hewitt said, it did close in the early days of the pandemic. That was a national diktat, and that's what we did. There are very few services and facilities that were closed as a result of the pandemic that haven't yet reopened, and the MRU is one of those. RWT are not in a position to reopen it. They've got some really serious staffing issues, as have MPFT, Midlands Partnership Foundation Trust. So the CCGs are actively working with a couple of other providers to look at procuring a step-in service, which means it can reopen again. The kind of staff that the staff that sort of run MRUs, their skill set is in short supply and in great demand. And whilst people may well think with the pandemic's over, it's far from over, and we've still got workforce pressures as a result of people testing positive with COVID, which is exacerbating the situation. So to cut a long story short, fully committed to reopening it, working with a couple of alternative providers that could step in. There may well be a procurement process we need to go through, which we're exploring at the moment with our legal advisors. But the view is that we want a service up and running for the people of Cannock in early summer. We're probably looking at around about June, would appear to be realistic given the process that we need to go through. The other thing to mention is that later on in this item, we'll update you all on where we are with the urgent emergency care engagement and consultation process. The future of all urgent emergency care services will be tied up in that engagement consultation exercise. So this is very much about getting the MOU up and running, but that will be, its long-term future will be very much part of a redesign of the urgent emergency care system, which we'll talk to you about in a moment. This isn't something that we are just doing locally. It's part of a national mandate in terms of this is what good looks like, and all systems, including ours, are required to put those services in place and transform how they deliver those services in the way that's sort of set out in the national guidance. So this is very much about getting the MIU up and running as quickly as we can. And its future and the future of all urgent emergency care services will be tied up in that wider consultation, which Jenny and Helen will talk to you about in a moment. We also discussed on Thursday, Chair, me coming back in April, I think April the 11th, where I think we will be able to, I'm confident, have something far more concrete to talk to elected members about in terms of what's actually going to be in place, when's it going to be up and running, when can people walk through the door and receive those services. Just one final comment, we have actually listened to what people have said in terms of what they use the MIU for, and the service model going forward will very much be designed to meet those needs. So around about half of people go there with a minor wound, and it's sort of wound dressing, and a raft of other issues and elements, as Councillor Hewitt talked about before. So we very much want it, when it does reopen, to be designed to meet the needs of the population that used it pre-pandemic. Thank you, Chair.
I don't want this to turn into a Cannock MIU scrutiny session, because obviously there is local scrutiny that has been done on this element for a number of months, if not the last 18. I'm going to just sort of take two contributors, but I also note that there is a proposal from you, Marcus, to come back on the 11th of April, just with some more firm timelines for when the operation might open. I'll take Phil Hewitt and then Martin, but brief on the basis this isn't a scrutiny session of the MIU, because it isn't part of our papers.
I fully accept that, Chair. And thank you, Marcus, for that comprehensive answer. So my one question is, so the target is to open the MIU unit in Cannock Chase in June?
Yes, that's what we're working to. Yes, that seems realistic at the moment, yeah.
Thank you.
Martin.
And thank you for indulging me, Chair. I genuinely appreciate it.
Thank you, Chair. So I just wanted to reiterate on Phil's comment for clarification, June.
Yes, we are looking at June. The only reason I paused...
when can we let local residents know that the MIU unit will be opening in June?
As I said, I'm certainly very happy to come back at the Chair's invitation on the 11th of April. I think I'm probably as optimistic as I can, given the conversations with the alternative step-in providers, that we'll be in a position for that to be June. If there are any issues around how we procure the service as a step-in service, there could potentially be some delays there, not anticipating them at the moment. And if the COVID situation worsens significantly, that could have an impact, although that doesn't necessarily seem likely at the moment, although the pandemic's not over. So as I sit here today, I'm as confident as I can be it'll be June. If anything changes, we'll obviously let you know that on the 11th of April. So probably tentative but optimistic is probably how I would summarise it, Chair.
Thank you, Marcus. That's really helpful. I'm going to close that element because I know that you want to move on to the wider bits, but I just want to make sure that people are clear that it's June this year, just so that we're all on the same page. So, Marcus, back over to you and your team. But thank you for that statement. Bearing in mind it is one of the few operational units that isn't reopened post-COVID. So thank you for your clarity on that. Over to you, Marcus, and your team.
Thank you, Chair. So, Jenny and Helen, do you want to kick off with, I think you've got a few slides to run through, haven't you? Thank you.
We have them, thank you.
Thank you, Chair. Thank you, Marcus. So I'm Helen Slater. I'm Head of Transformation across the Staffordshire and Stoke-on-Trent CCGs. We came to you in the autumn last year to outline the process that we were looking to undertake in terms of our involvement activity around the transformation programmes. Prior to COVID, we had large-scale system-wide transformation programme that covered a number of clinical areas. Through COVID, we saw a number of service changes, Cannock MIU being one of those, the others in relation to maternity services and some other urgent care changes as well, which have been reinstated as well. So last summer, through the Transformation Board, we decided to uncouple some of those transformation programmes so that they could progress at pace. Obviously, there was the implications of the temporary suspension of the birthing service at the midwife-led birthing units at both Lichfield and Stafford. There was the conversation and the involvement activity regarding the inpatient mental health services at the George Bryan unit in Tamworth, which was affected by a fire in February 2019. There's the ongoing discussion and involvement regarding the development of urgent treatment centres and the review of the emergency departments. And then, in addition, last year, the government launched new guidance regarding the development of community diagnostic centres, which we see as an enhancement to our elective recovery plans and diagnostic services across the patch. So that was an area of work that we wanted to make sure that we'd engaged our population on in terms of the emerging developments and the emerging guidance that we had at that point in time. From a CCG perspective, we had the difficult decisions process that was paused as well through COVID, and we wanted to undertake a sense check involvement activity before we continued the options appraisal process for that. We recognise that the inpatient mental health service provision in the southeast of Staffordshire is now aligned to the mental health transformation programme and primary care transformation programme across the whole of Staffordshire, and we want to make sure that we are fully aligned with the new guidance that was launched last year as well. We currently have on hold a couple of the programmes that we did start work on prior to COVID around planned care, integrated community hubs for the southeast and southwest of Staffordshire, and the integrated community beds in southeast and southwest Staffordshire. And there is a proposal that we pick up those areas of work as we go into the new financial year, now that we've got more of an understanding of the impact COVID and the implications of the planning guidance that has been launched and that we're working through in terms of our system operational plan. Next slide, please, Jenny. So I'm just going to hand over to Jenny. In the paper that you've received, there is more detail in terms of the outcomes of the sense check involvement activity, but Jenny's going to talk you through some of the highlights before we talk through the next stage of the process.
Thanks, Helen. So my name's Jenny Fullard. I'm the Communications and Engagement Service Partner working within the ICS. As Helen says, we started this conversation in 2019-20 when we ran a large listening exercise to seek people's comments and feedback on these services. Following the COVID-19 pandemic, we recognised last year that we needed to go back out and just refresh our understanding of people's experiences during COVID-19 and since that exercise in 2019-20. That's recognising that we've had to work differently, delivering some of these services during COVID-19, and we wanted to understand people's experiences. We also wanted to understand any potential impact, either through the pandemic, recognising that there's been both positive and negative impacts, and we wanted to understand that as we work to develop those models of care and proposals, and we wanted to seek people's comments on those models of care. The other part we wanted to do was just sense check for the larger programmes, urgent and emergency care and difficult decisions. We wanted to sense check the desirable criteria, which would then help us to assess these proposals that we're working on at the moment. So the full reports of findings are available on the Together We're Better website, and obviously the links have been shared within your report as well. So I'm not planning to go through everything in a lot of detail. Just to give a high-level summary. What I would say is that the reports of findings have been shared with clinicians and staff from the different programmes so that they can inform the work they're doing following the wealth of comments that we've received from staff, service users and different partners and community groups. So as a summary, maternity was one of the first exercises that we went out with in the summer of last year. We received 240 survey responses and had 28 event participants. What was pleasing is that 75% of those respondents had used maternity services in the last 3 years, and 28% of them respondents were expecting a baby. So we did reach into those maternity users and got a wealth of feedback from them. 67% of those respondents agreed that the continuity of care proposals was a good model. And 61% agreed with the proposed on-demand model that was detailed in the literature that went out. Areas for improvement included better support for birth planning, communication, consistent advice, and this is a particular issue through COVID-19, enabling partners to attend scans, and that was something we heard quite clearly through the involvement activity. Urgent and emergency care, again, a good survey response, 428 survey responses. 88% of those respondents were patients and public. And again, pleasingly, 84% has used urgent emergency care services before COVID-19 and 65% since COVID-19. So we've received a raft of information in terms of accessing A&E departments, minor injury units, walk-in centres, NHS 111 and urgent GP services as well. We did receive some mixed feedback in terms of the model of care. So 48% said they were concerned or very concerned, 27% were either unconcerned or neither concerned or concerned. Sorry, that didn't come across right. Neither concerned or unconcerned. That shows me that as we go through this journey and as we're developing our proposals for the urgent treatment centres, we do need to do more to communicate what urgent treatment centres are, the national mandate and the potential impact from those urgent treatment centres. And that's something that we will be picking up. Areas for improvement, again, included things like waiting times, improvements to NHS 111. I think this was around consistent access to X-ray and opening hours. Care for the elderly and communication. So similar themes to that we heard in 2019 as well. Next slide, please. So, In terms of mental health, this obviously refers to the inpatient beds in South East Staffordshire. We had 80 survey responses and 29 people that joined us in our online events. 26% of the individual respondents used the mental health services and 22% were NHS employees. We asked people about their experiences of the George Bryan Centre, the St George's Hospital in Stafford, and also community services, recognising the enhanced community services that have been in place since the fire. And we received mixed feedback for all of those different services. Areas of improvement included communication, staff access, quality, continuity of care post-discharge. 85% of respondents strongly agreed with the principles of the model. Community diagnostic centres. So this was a survey that we ran in the summer of last year, and we had 148 responses to that survey. Now, that was very early engagement activity to help inform a bid that went to NHS England and improvement. 13% of people were currently, at the time of the survey, accessing diagnostics, and 41% had access services in the previous 6 months. And the key themes that came across were around access, parking, and the importance of accessible locations. And finally, the other survey work that we did was around difficult decisions, and that was in the autumn of last year. We received 306 survey responses. 96%, the vast majority, were around hearing aids. And 52% of those respondents said that the NHS should fund provision of care and hearing aids. 41% said it should be available to anyone with hearing loss. We received 12 responses to assisted conception. There was mixed views on funding, and it highlighted a need for clear eligibility criteria. 8 responses to male and female sterilisation. 100% of the procedures should be available for anyone. And 11 responses to breast augmentation and reconstruction. 100% agreed with NHS funding for breast cancer patients and clinical reasons, but there was support for private funding for cosmetic reasons. And finally, 17 responses for the removal of excess skin. Most were in support of NHS funding. 18% of respondents classed it as a cosmetic procedure that shouldn't be funded by the NHS. So a huge amount of feedback and comments that we've received, and our clinicians and staff have been working through those very detailed reports of findings that are on our website to help inform the next stages, which we'll talk about in a moment. I think what's clear for us is that we're not just going to stop our involvement activity after these reports of findings and after that initial activity last summer and autumn. We recognise there's a need to do continuous involvement, and we recognise that each programme is at a different stage and there may be different levels of involvement required, and we'll only really know that once we've gone through this process and have the business cases and those options available, so we can determine the level of change and the impact that there will be. And we'll obviously want to continue to inform and involve the committee at every stage as that detail becomes clearer. We will be taking a tailored approach to our communications involvement activity, and that will be including virtual and face-to-face activity as appropriate. What we have identified through our reports of findings is that there are some seldom heard groups that, despite our best efforts to reach different community groups, we recognise that we still had lower responses from them. So gypsy and traveller communities, ethnic minority communities, I've also added in carers, and I'd also say younger men as well. So we're going to be continuing to reach into the voluntary sector and connecting with Health Watch to try and involve these different groups in our conversations going forward. The next part is that for a number of our larger programmes, so in particular the inpatient mental health beds, the difficult decisions and urgent and emergency care, we're recruiting to reference groups, and the aim is that those are balanced groups that will help us to sense check the proposals that we're developing and help us to understand, is there anything we should be considering as we develop our business cases. And that's almost the next stage of that involvement activity for those programmes, and it's what we're working on at the moment. And I'll pass back to Helen just to talk through next steps.
Thank you, Jenny. So as Jenny has said, we're utilising the wealth of information from the report to findings with each of our transformation programmes. Following the development of those reports, we've held technical sessions with both clinical commissioning leads, and we've invited Health Watch to those technical sessions so that we can understand any of the impacts on the clinical models and being able to shape those. Following on from the urgent and emergency care technical event that we held in December, we developed a paper that has gone through to all the trust boards within the provider organisations to outline what the implications are as we move forward with the programme. And we have started to develop that stakeholder reference group and the materials that we would need to share with the public to outline the emerging proposals at this stage in the process. As Jenny has said, we're continuing to work with service users and looking at different methodologies in terms of how we can engage as we go through this. So if something comes to light, as we know that these transformation programmes aren't a linear process, so if something emerges through the discussions with both the clinic with the clinicians or through the public, we have the opportunity to reach out through the networks that Jenny and her team have got in place. We are also developing the further data analysis and travel analysis, which will support both the quality impact assessment and the equality impact assessment that will be taken into consideration with any of the proposals as we move forward. And what we want to ensure is that all of the proposals that we take through the different stages are viable proposals, and we recognise that at certain stages there will either need to be a trust decision as to whether a proposal is viable, or it will need to be sense checked through the options appraisal process, either with the technical group or with the patient and public groups. And we have a process in terms of the weighting and the scoring elements for the larger programmes to undertake that piece of work. We need to understand the level of change that is needed across each of the different geographies. So we are mindful that for some of these programmes, they are specific to a geography, but for some of them, they are across the whole of Staffordshire and Stoke-on-Trent, and we need to make sure that we're recognising the impact of the different needs of the populations that are impacted. And we recognise that this process has already taken a long amount of time, but we want to make sure that we are following both the NHS England assurance process and our statutory duties in terms of making sure that we undertake this process with rigour, and making sure that we follow our the steps that we should be taking to develop the business case and any further involvement activity that we need. And we will continue to keep you updated as those proposals develop. Just to say, in terms of some of the key programmes, in terms of those stages, so putting some of this theoretical information into practical application, the difficult decision stakeholder event, we held the first one last week, and the second one is taking place next week, and we've got good representation from across the population to discuss the 5 clinical areas within the difficult decisions process. And we have a stakeholder event for the George Bryan inpatient service provision this afternoon. So we've got a 2-hour session, and we've got good sign up to that session, and we hope that next time we can bring you the report of findings from that involvement activity as well. Just to say, in terms of maternity, we recognise that we did bring through the a presentation to you last summer regarding the maternity challenges, in particular around the workforce, and looking at how we could reinstate services at the freestanding midwife-led units at both Lichfield and Tamworth. Those services still remain temporarily closed, and it is still the ambition to reinstate those services with the on-demand model. But at the moment, the challenges around workforce have prevented us from being able to reinstate those services. But as soon as we have an updated position from each of the trusts in terms of the timeline for that, we will of course bring that back for due consideration. Next slide, please, Jenny. So I'm not going to take too long to talk through this slide, but
can I just interrupt? Can I just encourage you to bring this to a conclusion so we can ask
yes,
some questions,
certainly.
please?
Yeah. So this slide just talks through the different stages that we go through in terms of both the technical involvement, but also the patient and public involvement. So Jenny, next slide, please. And as I've talked through, we have both the hurdle criteria, which is the technical essential criteria that we have assessed each of the clinical models against. And the second step, most importantly at this stage in the process, is the desirable criteria that's informed by the patient and public stakeholder groups. And the latter stage of the process is understanding the impact assessments and the financial information that will all be presented to NHS England to demonstrate that they are financially viable. So, and then this is an indicative timeline, particularly around the George Bryan inpatient bed discussion and the difficult decisions process. But as I say, we will keep you updated with key stages as we go through those. That's it from me. Thank you, Chair.
Love that last slide. You could spend hours on trying to understand that. That's great. Thank you for that. I'm just going to throw the floor open to questions. I'm going to ask one myself then on that basis. Thank you for the presentation. One of the things that is noticeable is quite a few of the numbers in terms of consultation responses are all sort of underneath 1,000, some of them are sort of in a couple of hundreds. Bearing in mind that this probably covers Staffordshire and Stoke-on-Trent, and I'm not speaking on behalf of Stoke-on-Trent, obviously, but you probably to about 1.2 million people, sort of in that sort of catchment area. It's a relatively small number of people who are engaged in the dialogue, and that's not really a criticism. It's just an observation, and the real question is, do you feel that's representative? And second of all, are there other ways that could be adopted to try and get more people engaged in these really important discussions? Because there's no point in, once it's been through the whole of the process, people being concerned by the outcome. And one of the alternatives I was thinking of is whether the role of PPGs had something to play.
Really?
Mark, I was going to say, do you want me to have a go at that one? So I would always love the numbers to be higher. So, and we always encourage as much uptake as we can. What I would say is, for where we are in the process, and we've been working very closely with the Consultation Institute, who have been looking at everything that we've been doing, the methods that we've been using, and have also seen those reports of findings. I'm confident in where we are in terms of the process. And as I said, I think we need to do continuous involvement. So the activity isn't going to be stopping following those activities that we did last summer and autumn. We know that there are certain groups, as I've said, in terms of particularly ethnic minority groups, gypsy and traveller communities, potentially even carers, that we would like to do more work, and that's what we will be picking up over the coming months. And I think as we go through this journey with these different programmes, we will be looking at what's the appropriate involvement activity that we can do to help encourage more uptake of those different programmes. In terms of, is there other ways, other methods that we can adopt? We're constantly looking for new ways. What I would say is that if I look at the maternity involvement activity, we've actually seen a lot higher response this time round than in 2019-20, and some of those digital channels that we've been using, and we've even tried social media advertising for some of these programs, and we saw an increased uptake following that social media advertising. So I think we have actually got a lot that we can learn in terms of the activity that we've done and take forward for the future involvement activity. We're also having conversations with Health Watch and voluntary sector organisations because we're keen to work with them and use their networks. And that's conversations we're having at the moment as to whether they can go out and support us to have these conversations as trusted voices in some of those communities. But equally, very happy to accept other suggestions either today or via email if there's any other methods that you think we can use.
Thank you for that, Jenny. My learned colleague next door to me suggested to continue to focus on those people who are being treated, which I know you've picked up as part of mental health, but also, you know, just really picking up those people who've got first-hand experience. And Angela.
Thank you very much, Chairman, and thank you for your presentations, Jenny and Helen. Can I ask, one of the main problems in Stafford area was the loss of the A&E department a few years ago. Are the ICS looking at reopening the A&E department in Stafford and County Hospital with the impact of the increase of the population in Stafford now? Could you answer that question for me, please? And can also ask, can we have more of a, in doctors' surgeries, can we have some sort of pathway for people to follow regarding mental health? Because there's no information, as I've seen in doctors' surgeries, with any pathway for people to be able to follow. If it's just a poster in a doctor's surgery with some sort of where they could go for help or anything like the Samaritans or anywhere where they can focus on...
Anne, I think we're slightly off subject.
Sorry, I do apologise, Chairman, but I just want to make sure that the ICS are taking mental health seriously.
So certainly just picking up on the mental health question, certainly something that we can feed back to each of our mental health providers. We do have centralised telephone numbers that we can make sure that are circulated, but also the voluntary sector organisations that could help patients or families who need that additional support. And certainly through the development of the business case, we are looking at how we make sure that we communicate better in terms of people who need to access that service. In terms of the conversation around the A&E department at County Hospital, we are looking at all of the emergency care portals as part of the options appraisal process for the urgent and emergency care transformation programme. We are looking at the activity that is going through the department. So we've looked at, as part of the options appraisal, the activity that went through prior to COVID, during COVID, but also looking in terms of what the activity is now, what the types of conditions are, and what the clinical workforce would need to be for that. So it is part of the ongoing options appraisal process. Marcus, I don't know whether there's anything else you would want to say.
No, well, you covered it nicely. Thanks, Helen.
Thank you, sorry. Anne, is there anything you want to come back on that's relevant to today's papers?
No, Chairman, thank you.
Thank you. So I think I've got Keith first, and then I've got Janice, and then I've got Colin, but let's do Keith first.
Thank you, Chair. Just a couple of observations which might need clarification for myself, because it's quite a lot of information to take in, and so same as the next item as well. It says some of the work that you're doing is future projects, integrated care, community hubs. I just wondered how close they are to the integrated care hubs and whether they're sort of combined or not at the case at the moment in terms of the research that you're doing. In terms of your engagement with the voluntary sector, I applaud you for that. I think that's highly important at the moment because lots of these requirements are softer than people might need in the first case. And apologies for us men being so awkward to get hold of. I believe that you mentioned men at one point after carers. So I'm sorry if I'm being awkward in terms of coming forward to give you some information on behalf of the male members of this committee. But I do like the idea of some of the carers groups and things being involved and some younger people. And I just want to know how you're going to engage with those because many of the carer groups, particularly in my area at the moment, are not still up and running from COVID. They're quite old, older generation of people that tend to look after their loved ones. And I don't know how you can overcome that over the coming few months when you're trying to put that information to them. In terms of an issue that I still think is personally is part of how the NHS works at the moment, is the fact that there's almost too many points of contact everywhere. You might go to a GP first, then you might have to be put off to another service. I think what happened earlier in Cannock about people, was mentioned about people having to go to different places and not necessarily having their say in where they're going to have the look after care once something's happened or you've been discharged. I still think that you need to, somewhere within your plans, to have the people to have access to their own idea, almost. I know that notes are kept secret and everything else, but the idea of allowing people to then understand what the next steps are after they've had any process or any interaction with the NHS. It doesn't add up to me. That's the point I think I'm going to be making in terms of all these decisions that you're making. I do think that allowing people to have some control over what they're going to be doing in the future to make themselves better is something that I think would be something that we would look after from the county council perspective, giving people that control. And I think that's important within that, with including mental health as well in particular. And then just very specifically at the end, the George Bryan Centre discussion this afternoon, I just hope that you do have someone from the Kniveden group that have now been closed and everything else. I know they've contacted me and I'm trying to get some help for Support Staffordshire from them and all the rest of it, which is sort of confidential, but anyway, I've said it now in the meeting. But I'm just hoping that discussion will be open and about the services that are being looked at, particularly in North Staffordshire. Thank you.
Thank you. Marcus, who's starting with those?
Well, if Helen maybe starts off with the integrated care hubs, I think there's four questions in there. I think Jenny can then pick up the stuff around the voluntary sector and how we engage with people. Might say a little bit after that, Helen, around the whole personalisation and self-care and prevention agenda. I think some good points made in there, and then also the George Bryan. So I think they were the four areas. If you want to maybe just pick them up in that order, that would be helpful. Thank you.
Certainly. Within the case for change that we presented in 2019, which was the document that accompanied the system-wide transformation programme, we outlined the clinical model for the integrated community hubs, which was focusing on long-term conditions and frailty support. The same clinical model was subject to the consultation in North Staffordshire a couple of years ago, which MPFT are leading on the implementation of those four hubs in the north. We will be starting the conversations in late spring with key partners around looking at how we can implement that clinical model, but taking into consideration some of the service changes that have happened due to COVID in terms of remote consultations, looking at how the multidisciplinary teams work differently, and also how we can support people in different ways. So looking at how we can link in with virtual wards and some of the other developments that have come on board over the last couple of months. I think linked in with that clinical model, just picking up on the third point, is around the personalisation, the prevention and the self-care, which is a fundamental part of that. I think it is getting increasingly complex with some of the guidance that's now been issued in terms of community diagnostic hubs and elective care hubs. So it's being very clear in terms of which elements. So the integrated community hubs is around that long-term conditions, frailty, clinical model. The community diagnostic hubs is around supporting the elective care and utilising some of the large-scale diagnostic capacity for pathways that need CT, MRI, endoscopy type procedures, and making sure that there is a separation of both the elective diagnostic pathways from the urgent diagnostic pathways, so that we can manage patient pathways more effectively over the next few years. And And as I say, that's linked in with the elective recovery and the development of elective hubs, which we'll be able to outline. I think we've got an update in terms of elective recovery coming to the board in a couple of months' time. So that's how all of these sort of connect together, and we are aware of the interdependencies between each of these different clinical programs, and some of the challenges and the risks, and obviously the challenges particularly around our workforce at the moment to get some of these implemented. But we will keep you updated in terms of how we will work through that process. Just before I hand over to Jenny in terms of the carers, the discussion this afternoon is around the inpatient proposals in relation to the George Bryan beds that were there, but we are aware in terms of the conversations around Nivden, so we will pick that up if it's brought to our attention this afternoon.
Thank you.
Jenny?
Sorry.
Yeah, so just in terms of the involvement activity, I think what we recognise is that we do need to connect in with those trusted voices within the communities. That's the best way for us to reach into these groups. And I think we've learned a lot during COVID-19, and it's about us connecting in with our council colleagues, fire service colleagues, and the voluntary sector who work with many of these groups. We are trying different approaches, and these are the conversations we're having at the moment. So, for example, is there a little pot of money that we could perhaps commission some of these groups to actually run focus groups for us, and bring together safely these people and enable them to participate in the conversation? And that's some of the things that we're exploring at the moment with our Health Watch and voluntary sector colleagues. So I think each programme will need a different approach, and we are very happy to be having those conversations to see what's the best approach. And it may take several attempts and several times of us going back to these groups to reach out to them.
Thank you, Keith.
Thank you, Chair. I would hope to include, obviously, mental health in the bigger picture as well as the more specific picture. I think that's something that I would very much like to see, and I dare say Anne and others would like to pick up on that as well, maybe in the future. The other thing is that you mentioned money then for a moment, about the idea of trying to get this interaction with the community worked out a bit more. You shouldn't have mentioned that, really. Can I suggest that we actually take that further forward within this group that we're in at the moment, and that maybe use the committee members of this and even members themselves in a wider picture, so that you, rather than keeping us just integrating with us during this health committee, that maybe members, those that wish to, could in fact get involved in trying to assist some of these organisations in attending some of the meetings. My fear of a lot of times with voluntary sector is that they work at weekends, they work in the evenings, but they're not available during the day. And that's something that we picked up on during the all-party working groups processes that we did over 4 or 5 years. And I do think that maybe having some funding or some finance to be able to get some access to some of these groups through members, I'm not saying it should be done without it, might well be something that we could look at. I'm just suggesting that, Chair and Vice Chair. Thank you.
Do we want to note that? Do you want to just talk a bit about some of the work you've actually done in terms of trying to engage with those groups? Do you want to talk about the 3 voluntary sector forums you have set up as part of the ICS work? How do you want to answer that one?
Jenny?
Yeah, so in terms of, as I said, we are piloting this, and we're looking at other systems, and again, just recognising that there are some of these seldom heard groups, and they may need a different approach. So it is a pilot. The conversations we're having with, to start with, are with Health Watch, VAST and Support Staffordshire. And just as you've said, Chair, there is ongoing conversations happening within the ICS, particularly with VAST and Support Staffordshire, about what is that long-term relationship with the voluntary sector, and how do we build alliances so that we're fully working with and connected in with those different voluntary sector groups. Very happy to explore opportunities for members to support us in having these conversations, and to build this into some of the pilot. So I'm happy to look into that further.
Thank you, that's helpful. I don't think Keith was looking to be paid himself personally. Janice.
Chair, thank you. I think the point that has already been made, and I certainly don't wish to labour it really. I'm assured with the attempts at the further engagement. I think it's helpful in the report that we consider percentages, but also the number of respondents. And I appreciate that, and I think that needs to, as it is being developed in terms of being able to look at the further segmentation of the actual respondents. The only part that I think I would want to still make, and certainly when we start focusing on the George Bryan Centre, you can see the attempts to engage with stakeholders, the emails, the telephone calls. I'm a big fan of data, but I think the reliability and the confidence in the data also needs to be acknowledged. And I think that the original statement on page 48 could imply that the decision has been made and the data has been collected to support that decision that's already been done. I just needed to make that comment as opposed to a specific question. As I say, I think the other points have been well made. Thank you.
I think it is probably just worth picking up that last point you did make. Is that one for you, Jenny?
I think this one might be for Helen, but I'm happy to...
Either, sorry.
Yeah.
So in terms of the data that has been developed for the options appraisal for the George Bryan process, we have followed the exact same process as we would for any other transformation programme in terms of looking at the activity prior to the service change. So unfortunately, it was a fire that led to that service change. We've looked at the information prior to the fire and then in the subsequent 3 years since the fire, and obviously taken into account the impact of service changes through COVID. We have taken into consideration the findings from the engagement and involvement activity, but also in terms of national evidence and also the quality and safety of service provision in that interim period. And then started to undertake the impact assessments from both the quality, equality, quality and travel analysis impact that are incorporated into the proposals at this stage in the process. Obviously, the stakeholder event this afternoon will be a sense check, and we will take on board the findings that will be taken into consideration by MPFT, who are responsible for the business case, and that overall business case will be subject to NHS England assurance, West Midlands Clinical Senate, and then will be presented to yourself to outline the final options.
Janice, do you want to come back?
Yeah, just to look at when that is likely to be, the timeline, when the options will come back. Thank you.
Okay, so we are looking to take the business case through the assurance process late spring, early summer, so that we can come back to you in the summer in terms of that process.
And just to confirm, it is diarised in terms of the forward plan going forwards, but we'll be flexible based on the input from residents and users. Who have we got? David? No, Colin. Sorry, it's Colin.
Thank you, Chair. Just on your continuous involvement with hard-to-reach groups, really. You've given an example of Gypsy and Traveller groups, but also you've ethnic minority groups as well. Can you just sort of enlighten us a little bit how you're going to try and improve that? Because clearly, you may well have answered this question already, by the way, but obviously they are transient as well. Not sure in Staffordshire how many sites for Gypsy and Traveller sites, permanent sites we've got. But when they are, transient, it is very difficult. So if you can just enlighten us a little bit more about how you reach those groups, I would appreciate it. Thank you.
Okay, so as you say, it's not easy, but it's absolutely the right thing for us to be doing, and I think we just need to keep trying to make these links with these communities. We know that there are networks already in existence. There's trusted voices that have been connected with during the pandemic, and we want to build on those. So already we've had some suggestions of people that we can speak to start those conversations. I think the other thing for us is looking at those different areas. So if I was to look at, for example, the Burton area, there's quite an active African and Caribbean society. We want to try and reach into that group. We recognise during COVID-19, many of these groups weren't meeting. Hopefully, over the coming months, they will start to meet. And as I've said, it may be that we can work with those community groups to offer to host a session, or they may be able to host a session that we can come along to and speak to these people. So I think there's no one method and there's no one approach to each of these communities. It is about having those conversations with those different trusted voices and just trying to get a way in so that we can then go and speak to them about a range of different services, including these programmes.
Thank you. Can I just come back to you on just one thing, or a couple of things actually? You just mentioned the in Burton. I know that the Afro-Caribbean group there in Uxbridge Street are very sort of, you know, that they are a big community asset. So I'm sure that they would welcome your involvement with them. I'm very sure about that. There's also a problem, I think, that a lot of the society, especially the Gypsy Traveller Society in particular, you know, they're very male-dominated. So I would imagine it's quite difficult to reach the females in those societies. I mean, you know, I'm sure you've probably sorted that, or you know, you're working on that. I hope. Thank you.
Absolutely, and it is that local intelligence and knowledge that we need to build into our approach. So, for example, I know during the COVID-19 pandemic, we worked very closely with mosque leaders who were able to give us insight as the best way to approach certain groups. We've run events that are female-only events. We've had translators, and so some of that knowledge and understanding is absolutely what we want to take forward into the next stages, and recognising those different approaches and using that local intelligence.
Thank you. Last on this one, Anne Edgeler.
Thank you, Chairman. It's just a comment, actually. A few weeks ago, I sat in a meeting listening to the service users of the John Bryant Centre, and just to say that their main concern, if that was not reinstated, the travelling time and the travelling actually to Stafford. So I just wanted to make that comment because I've listened to the service users at John Bryant.
I think that's probably just a noted, unless there's anything that you want to come back on. So let me just take Chair's prerogative then and just ask a very long rambling question, which you might want to just sort of think about. Where it starts is on page 52, paragraph 7.4.2, which talks about the difficult decisions. And it is clear that the hearing aids issue is still very much live. There are as many respondents on the hearing aids as maternity. And I guess this committee, if we stood far enough back from that decision, would want to see a consistent approach for residents of Staffordshire. So I hope that where we will get to overall is something which is consistent across all of our geographical areas. And presumably the ICS will bring that as part of the outcomes. And obviously that would need to be subject to local need, because there's obviously no point in putting services and other things available if people don't need them, based on demography and all sorts of other bits and pieces. And it's a decision based on need rather than finance. But that then takes me to a different set of thoughts, or a very similar set of thoughts, which is, I wonder whether you need, as part of the process, just to keep reaffirming what the minimum standards are as part of the design criteria. I.e., what is your key design criteria? One of them, presumably, is a standard service for all residents across Staffordshire. Presumably, another one would be something related to ease of access. A third one could be based on using the most up-to-date accepted NHS principles in terms of design. And I think if you keep referring back to those so that we're all clear that that's what you're designing to, and then we can hold you accountable against those, would probably be quite helpful. I know it's implicit in what you've probably designed, but it might be just useful having that as a background piece of work that you permanently keep coming back to and saying, that's our terms of reference, that's what we're designing to, that's what we're trying to do for the benefit of our residents across the whole of the county. Sorry, it's a really rambling long point, but hopefully you take the main substance of the point, which is about the design criteria and coming back to them. Could you just give us a couple of thoughts on that, please?
Yeah, certainly, Chair. So as with all of the processes, the process that we've gone through, we take on board the national and local guidance that we have. We make sure that we're keeping up to date with any changes in national guidance. We take into account the health inequalities and the equality duty that we have as a organisation. And what we are aiming to do with all of these programmes is to make sure that we do have that consistency of approach in terms of service provision, and being mindful in terms of those impacts in terms of access, and as we've demonstrated in some of the responses that we've given today. So we take on board what you say, and I think when we report back on each of the individual programmes, we'll be able to talk you through each of those different technicalities, so that you can take due consideration of the process that we've undertaken.
Thank you, that's helpful. I don't see any further contributors to this item. I think we're asked to note the reports and progress, and that you will come back once you've further informed business cases and continued consultation with all relevant stakeholders, including users of those services. I'm not getting any other indication, so we will note that. Are we committee happy to note it? Right, okay, brilliant, thank you. Thank you for your contribution on that item. Can we move on to the item number 6, NHS dashboards?
Thank you, Chair. I'll maybe just start us off on this one, and then Helen can jump in and help me with any questions. I'm just conscious of time, and there is a fairly comprehensive report and a dashboard, so I don't wish to necessarily go through that in any great detail, although we can pick up on any items of detail in response to questions. I think one of the key messages is we were making really good progress on recovery up until winter, but we've had some real challenges since then. And I think it's fair to say that we're not alone across the country. There are some real ongoing challenges particularly around elective and cancer recovery, which are probably the two areas we want to focus on this morning. I think it's fair to say pre-COVID, I had no patients anywhere in any hospital that had waited more than 52 weeks for an elective procedure. I think as of the latest validated data, we've got over 6,500. And in terms of 104-week wait, that's people waiting over 2 years for treatment, we had none of those either pre-pandemic. I think we've now got about over 500 of those in our various different providers, and got some particular challenges at UH&M. So there are some national targets we have to hit. For instance, no over 104-week waiters by July. And whilst we're making progress, we are struggling on some of that. That's largely down to workforce and also the fact that the waiting lists have just got so long, they're going to take some time to actually reduce. We are making good progress on cancer in a number of areas, which is obviously one of the priority areas that we're focusing in on. But we still have challenges around, for instance, people on the 62-day pathway. So that's people who've been referred with suspected cancer, completing their first definitive treatment. So we've got some challenges there, particularly in areas like colorectal and skin. So some good progress on cancer, some challenges in some particular sites, and some real challenges in areas like, for instance, trauma and orthopaedics and general surgery in terms of elective waiting times. The dashboard shows an awful lot of red on it, which is a real area of focus for us as we come out of the pandemic and look to getting back to business as usual. One final comment, I guess, before we open it up for questions would be that you would think the pandemic's all over and done with, you bar the shouting. It's not. So at the moment, the ONS predicts that around about 1 in 25 people, if they tested, would test positive with COVID. So there's an awful lot of COVID out there. And whilst the vaccination program and people who are recovered from a prior infection gives us a high levels of immunity, that does wane over time, particularly as people become exposed to new variants, as we saw with Omicron. So there's a lot of people out there with COVID not getting as ill, not as many requiring medical attention, but we are now for the first time in many months seeing an increase in the number of people either admitted with COVID or testing positive with COVID. Now, it's fair to say that a lot of them are not in hospital because of COVID. Everyone is tested in hospitals, so some of those will just have COVID, but that's not what they're there for. But we have far more people in beds over winter than we had planned for. I think UH number planned for no more than 50 people with COVID in a bed. Those numbers dropped down to just over 100, and they're beginning to increase again. It still feels like a fairly fragile situation we're in, and it doesn't take much of an increase in people in beds with COVID before it starts putting significant pressure on our recovery programme, particularly around elective recovery. And I think as of the 25th of February, the 7-day total, there is nationally just over 6,500 people with COVID in a bed. As of the 8th of March, it was over 8,000, an increase of 28%. So it does feel like we're still in a fairly fragile position as society opens up, as the remaining restrictions are removed, as access to free testing for the 1st of April disappears. There are some risks there. I'm not for 1 minute saying it will be anything like the problems we had in the previous phases, but there are still some residual challenges around the pandemic that we continue to battle with. So elective recovery is a focus, but any significant increase in COVID pressures is obviously going to put a dent in some of those recovery plans. So, Chair, I'll probably pause at that point and happy to take any questions.
Thank you. Here, your point on COVID, Julie.
Thank you very much. I know that the free COVID tests are finishing in April, but my question is, we have found a new variant now from the Omicron, which has gone off. So what happens, because a lot of people are thinking it's all over and done with, they're going back to what used to be normal pre-COVID. So how are we going to know which areas have now got COVID? Because if people aren't going to test, because they're not going to buy the tests, how are we going to know that that COVID is in that area, that it is actually picking up? Have we got to wait until it's really too late, when we've stocked up, we've got the hospital all full again? How are we going to know? How are we going to go on that? How, as the NHS, are you monitoring that? Because this is something for the whole of the country. We've got to sort out where we go from here. It's, people are going back to pre-COVID, which is, as you said yourself, it's not gone and it won't be gone for a good while. So, where are we going from there? This is something I'd like answered. Thank you.
Certainly.
Marcus, you went down that route, so I'm going to let the question stand.
Yeah, no, I'm very happy to pick that one up, and it's a really good point. I think one thing to bear in mind is that not all tests were captured in the national data. So when you actually look at the test results, even when mandatory testing was freely accessible, only PCR tests were actually uploaded in the government statistics. Around about 1 in 6 lateral flow tests, people didn't actually do what they were asked to do on the box and upload to their positive result. So we're only ever capturing a proportion of the people that are testing positive. What we tend to put more credence in is the ONS data. So the ONS sample cases across the country. And we also have the REACT study as well, which asks people, a sample of people to test. So I think even when testing stops, we'll still have a fairly good idea around what rates of COVID are. And the 1 in 25 I quoted before is the ONS estimate. It is an estimate, but it's proven pretty reliable to date. I think one of the concerns around testing is probably more about the fact that if you don't have free tests, People may just carry on doing what they would normally do, going to work, going to school, visiting vulnerable relatives at home or in care homes. So, testing obviously gives us data, but it only ever captured a proportion of the people who would otherwise have tested positive. But I think we're relatively confident we will. Given that I think around about half of the genome typing is done by the UK, we're in a pretty good position to actually pick up new variants and also to get an idea of what COVID looks like in the different regions. What we tend to look at more is the number of people seeking medical attention, going to being admitted to hospital with COVID, because that's where the real pressure will be felt. Just one or two other points, Chair, is that as the councillor said, COVID is with us now. It's not going anywhere. Well, SARS-CoV-2, the coronavirus that causes COVID, which is the disease, is not going anywhere. It's endemic. It will be there in the background for the foreseeable future. There's only one disease that's been eradicated, and that's smallpox. All the other ones are there in the background. What we're seeing at the moment in terms of COVID cases, they are reducing, but there's still case rates are very high, and there's more people in hospital than we would like to see. The death rate as well, which we carefully monitor, deaths at the moment from COVID or with COVID are around about what you would see in a bad flu season. So it does feel as if immunity and everything else is getting us into a position over the next year or two where, as the government says, we'll be living with COVID, but it hasn't gone away. It won't go away. It will be there in the background. And as we all know, for many people, it proves to be a very nasty, serious illness that takes some time to get over. So I don't know if that provides any assurance to the councillor in terms of the questions you'd asked, but it's there, we're monitoring it, and we will do the best to manage it and deliver on the government strategy around living with COVID.
Julie?
Thank you very much for that answer.
Janice?
Yeah, if I could just go back to some of the data on here, notwithstanding everything that's just been said, if you could just go into a bit more detail for us on the cancer breast symptoms, the 2-week wait. I think the majority of this, you can see how the data is fluctuating, but that one seems particularly erratic.
Yeah, we've got, so one of the problems that we're having is around histopathology tests. So that's for cancer generally, and a particular problem around breast, and also breast pain. People are often referred through the 2-week pathway of breast pain. A large proportion of those won't be cancer, it'll be something else. So one of the issues is around diagnostics, and in terms of cancer weights, histopathology weights are around about 4 to 5 weeks at the moment. And if you're on a 2-week pathway, then that's quite a significant delay. A lot of work being done by our providers, particularly OHS, on addressing that. But yes, that's a particular challenge at the moment. What I would also say, whilst breast is highlighted, we've also got problems around colorectal and skin for different reasons. And again, it tends to be access to diagnostics that's the challenge. And for people who maybe aren't as familiar with the targets and the pathway, patients with suspected cancer are referred through the 2-week pathway, which means the GP needs to get the results back so they can decide what to do next. People who have a suspected cancer then need to receive their first definitive treatment within 31 days. And the whole pathway can be completed in 62 days. So that's 2 months from a referral through to a first definitive treatment. Given all the other pressures in the system, given just how pressured our workforce is, that's proving a very difficult pathway to deliver on. And as the councillor said, in certain cancer sites such as breast, colorectal, lower GI, then that's resulting in longer waits than we would like. Huge amount of resource is being thrown at addressing that, but we're not where we want to be yet, and that will take some months yet before we get into a position where we're if not fully back to where we were pre-pandemic, at a better position we're seeing at the moment.
Janice.
Thank you for that. Can I just press you a little bit further on the resources then? First of all, in terms of the access, is it difficulty accessing the equipment? Is it the staff, the personnel to man that? And then the next question going on, the resources that are being thrown at it, I'm sure will satisfy my first question. Thank you.
Yeah, I mean, the staffing is a massive problem. So we've got, if you look at some of the cancer sites, for instance, we don't have enough endoscopists. So one of the reasons we're struggling around, for instance, lower GI, lower gastrointestinal tract, is there aren't enough people to do the colonoscopies required to actually see whether or not someone has cancer. So that was a problem pre-pandemic. It's a problem now. So in certain specialties, yes, we do have problems around having enough trained clinicians to actually deliver the level of activity that we need, not just to reduce the backlog, but to stand still in some cases. So workforce is a huge problem. It's not really a money issue. The people are not out there to recruit and to pay. Workforce across health and care has been a challenge for some time. It remains that, and it's a particular problem in certain specialties. So there's no one answer to this, but we're aware of where the challenges and the blockages are. We're doing everything we can to address it. But part of it in the longer term will be money. At the moment, money's not the issue. It's more actually having the staff we need to actually carry out the procedures.
Thank you. I should just make one other comment, which is that there will be a dedicated session later in the year, calendar year, on workforce, because I think that we do need to take from across the system a discussion on workforce, because we'll continue to have the same discussions for the next 20 years if we're not careful, and we need to see what plans all providers, both in care, social care, and within the NHS, have to bring people in and keep people within the system. So it is in the forward plan going forwards. Phil Hewitt.
Thank you, Chairman. This is a statement, if you don't mind, rather than a. There's no question there. It'll be a short statement. Often in scrutiny, we challenge, and certainly at the beginning of this meeting, I put quite a strong challenge out to Marcus. So sometimes there's an opportunity to correct that. Sometimes there's an opportunity in scrutiny to say, thank you very much for doing a great job. So a number of months ago, I was quite poorly, and some of the symptoms I had were symptoms of cancer. And I have to say, anybody who's had that, it's pretty scary by any standards. I got in touch with my GP. My GP referred me on a 2-week emergency. I was seen well within that 2-week period, taken into hospital on the emergency care in Wolverhampton, X-rayed, done everything, blood tests, the whole lot. I was pleased to say I wasn't very well, but I hadn't got cancer. But what I want to make the point was we talked about the 2-week things, and for me, we often criticise, but for me that 2-week thing was fantastic. It worked absolutely brilliant. I had a quick diagnosis, and then further treatment after that for the challenge I had. So if you don't mind, Chairman, sometimes we throw bric-a-brats, but now and again we have to say the system works beautifully, and for me, it worked beautifully. Thank you, Mr. Chairman, and thank you, Marcus.
That's good to hear. Thank you.
I'm sure we'd all want to pass on our thanks to everyone within the system, both in terms of the NHS and social care, for everything they do for residents of Staffordshire, which I think is something we all endorse. Can I just? I was going to bring this item to a close, and Keith has beaten me to the flush. So, Keith, very short, please.
Thank you, Chair. A challenge. There we go. My concern really is that obviously you're producing all these statistics, which is great to see, and obviously there's some trend there. How are you going to try and improve the trend at the moment in relation to some of these 52-week waits and everything else you suggested, and also some of the breast cancer elements when they're still 25-30% below where your targets have been set? Is there anything else that you think needs to be done that will try and improve on that over the coming? I know that there's difficult reasons out there, and I know they're coming out of COVID and all the rest of it. But of course, in reality, these are people's lives that you're looking at on this particular thing. And I think we've sort of skated over that in some respects, and that's the greatest respect. And I know that they're here to try and help you to tell us how you're trying to improve that and whether we can help out on anything on that front. But how do you see this being developed, and what sort of timescale are you yourself looking at this? Is it 1 year, 2 years, or is it 6 months, 4 months, 5 months? What sort of timescale are you looking at to try and get some more green numbers onto these unfortunately fairly red statistical tables? Thank you.
The reality of the situation is this is going to take years, not months. We are making progress, though. I mean, the 104-week wait that we talked about, the target for that is to get down to 0 by July. We're making progress on that. Over 52-week waits, again, making progress on that one. Not as quickly as we would like, because obviously there's still people coming through the door and being added to the backlog. So you have to do 10, 15, 20% more activity to treat the people who are coming through the door as well as those are on the backlog. And I think the other point you made is well made. These are people, these are not statistics, who have lives to lead, who are worried, anxious, concerned, maybe people who are the main carer for someone else who's particularly vulnerable that can't provide that care because they've got a dodgy hip or knee or whatever. So the consequences of this go beyond sort of just reds and greens on a dashboard. These are people and their lives. So yeah, I do absolutely get that point. We don't have time to go through each individual pathway, whether it be an elective pathway or a cancer pathway around what we're doing. But there are some fairly obvious things that can happen either with or in the absence of national guidance. So, for instance, the main reason that we're breaching the 62-day pathway at the moment is around lower GI referrals. And actually, there are things we can do around that. GPs requesting a fecal immunochemical test prior to making a referral, for instance, means that you know whether someone tests positive before you make the referral. So you only refer those that test positive, which could reduce the number of people being referred on the lower GI 2-week wait by 60, 70, 80, 90%. So there are things we can do in terms of redesigning areas of the pathway. Nice looking at that nationally around providing best practice. But that isn't going to resolve the problem in its entirety, but it will certainly help in certain areas where we've got some real pressures. So I think we are coming back in a couple of months, I think, to talk about the elective pathway in more detail. And we can obviously, rather than just quote the figures at you, talk about what we're actually doing about it in terms of recovering the position in a number of areas. But I think the key takeaway is we are under huge pressure in the NHS still. That will remain the case for some time. This isn't going to be resolved in a matter of months. It's going to take years to get back to where we were pre-pandemic. Just one final comment around workforce. It takes a long time to train people in these clinical specialties. The number of people leaving the NHS is far higher than we would like to see. So I know the Secretary of State talked about not just recruitment, but also retention as well in the workforce. It's easier to keep someone that's been spent many years training and has developed that experience than to recruit someone new. So there is a lot of focus on recruitment, but also on how we make the NHS a place that people want to stay and work in, and try and reverse some of those early retirement decisions, etc., that people are making. The last 2 years has probably been the most challenging any of us have worked in the NHS. It's been difficult for everyone, but I think in the NHS it's probably been the most challenging couple of years of my career. And I haven't been working at the front line, actually treating patients or fully gowned up or PPE'd up on a COVID ward. Once you run a marathon, you know how to do it. It doesn't make it any easier if you've got to get up the next morning and run another one. So there is a pretty exhausted workforce out there, which does need to sometimes recover. So when we talk about recovery, it's not just recovering elective waiting times, for instance. It's also giving the chance for a really, really pressured workforce to also recover. And if we can't do that and give people the time they need to recover, then they will leave. And we have seen very high numbers of people leaving the service, which is a trend we want to reverse. So no simple answer to the question. It's a priority for all of us in the NHS, and we'll come back in a couple of months and talk to you a bit more about what we're doing about it. Thank you, Chair.
Keith, very briefly.
Yep, thank you very much for that. Yes, I mean, I concur that there's lots of different reasons why all this is happening, and just looking at it as a statistical exercise, there's obviously variation between the 6 different areas that you're looking at the moment, and I'm just wondering whether or not to try and stick on the more positive side of things, whether or not if there's some good practice that you've come across in these different areas that then translate into other areas that can improve the figures there, perhaps that's something that we would be interested to know and to see ourselves, so that it's not all just negative news and everything else, to try and get some idea of positiveness that's happening across the whole county. And I think that would be something I would be very interested to know yourself, and may even help highlight and help other areas to develop and hopefully take less strain off you all. But can I just also say at the final thing is, You know, obviously we all thank you for all the work you've been doing for the last 2 years. And am I doing the conclusion for the chair again? He's not paying attention. So I'll finish off doing no, I'm only joking. Okay, all right, thanks very much.
I love this idea that we have loads of chairs in this room. We want to do my summary at the end. It's very kind of you, but I'm more than capable of doing my own, Keith, thank you. Marcus, there was a suggestion in terms of best practice, which I'm sure you'd just want to sort of maybe say a couple of comments on, and then I will just summarise myself.
Yeah, I mean, that is a really good point. There are some areas which have maybe recovered more quickly for various reasons, and there's certainly some good practice that we would be very happy to highlight. As I said, nationally, lots of very, very bright people nationally actually looking at what's worked well, and we obviously that learning is shared with us, and yeah, we use it where we can. We'll put some examples of what's gone well as the areas where we've got some particular challenges in the next presentation. I think that's a really helpful suggestion. I'm just conscious, Chair, that Helen sat there sort of nodding all the way through without necessarily having a chance to say anything. Just before I finish, anything we've missed off, Helen, that might be worth sharing?
No, I think just in terms of the best practices, certainly for the cancer pathways, we're linked in with the West Midlands Cancer Alliance and Health Education England. So we're receiving best practice from our neighbouring ICSs as well, to make sure that we're working in conjunction with pathways that flow outside of the county and back in again in terms of that ongoing care. And certainly for the other elective care pathways, the Royal Colleges, for example, give us some really useful updates. So we do bring those into each of the discussions as we're reviewing each of the pathways.
Excellent.
Thank you. So just let me bring this to a conclusion, if I can, please. I think the point is it's very difficult when there's a whole set of red on a page to know which figure to look at and to spend time questioning. But I think if you spoke to many of the residents across Staffordshire, and they are all individual people, I think that point was well made. And they would probably talk about two things. One was access to GPs, and clearly that's a strand of work that we are looking at separately. I note from these figures, however, that there was only one CCG area, North Staffs, that increased month on month its number of face-to-face appointments. So that is a strand of work that is going on elsewhere and is still very much work in progress, clearly, because people need to feel that they can access the services they need, particularly as the GP is the front end to most things. But second of all, I think that we need to look at the plan that you've submitted to NHS England in terms of that recovery of the backlog of appointments and diagnosis and then into operations. And I think we should invite you to bring that plan so we can scrutinise that back in a couple of months' time, if only to make sure that there isn't opportunities that we feel might be there to speed it forward. I'm sure you're looking at that yourselves, but I think for residents we need to scrutinise that. Are we in favour of that as a suggestion? I've got plenty of nods. That's fine. No one seems to want to summarise after me, so I'm going to thank you, Jenny, Helen, and Marcus for your insight this morning. I appreciate it's a difficult job, but thank you for everything you're doing, and obviously anything we can do to recover where we are, so much the better. So thank you. You're welcome to stay or go as you so choose.
Thanks, Chair. Thanks, everyone. Bye-bye.
Okay, thank you for that point. So that brings me on to item number 7, the COVID update. I believe we have Mrs. Emily Dorbar, who is BEM. Have we congratulated you on that British Empire Medal before? I will get bored of saying it at some stage, even if you don't get bored of listening. We also have Julia Jessel, Cabinet Member. Julia, do you want to open anything up, or do you want to just contribute as proceedings go?
I think it's probably as well for you to have the presentation first, and then if there are any issues or questions, I think both Richard and myself are available. So I think we'll hand you over to Emily's very capable hands to present the update report.
I think we would echo your comments, particularly in terms of capable hands. We have your presentation on screen. You're ready to go, Emily.
Thank you, Chair, and good afternoon, everybody. Provided a update to start. So the Living with COVID paper was announced on the 21st of February. There are two significant changes. One relating to the legal duty to isolate following a positive COVID test was replaced with guidance to limit contact from the 24th of February. And the second significant change was the intention to cease free public testing from the 1st of April. Our activities in 2022 through to 2023 will instead focus on supporting high-risk settings. Those include social care settings and settings visited by those most at risk. We will monitor and respond at a local level to surges in the community. We'll be continuing our support of the vaccination programme and supporting our health colleagues, and we'll be retaining our COVID helpline and continuing to provide advice to the public. Although case rates have reduced significantly, they are starting to rise again. Most notably, we're seeing that in the 35 to 49 age bracket. However, it is to be expected as the restrictions have been eased. Hospitalisations of confirmed cases has steadily reduced this year. Apologies, I'll just flick back to demographics. You can see those age groups that I was just discussing on screen. All age groups are rising, however, most significant rises in the 35 to 49 age group. Hospitalisations of the confirmed cases has been steadily reducing this year. Especially over the last few weeks, we're seeing some small peaks in the last few days. However, the levels are much smaller when compared to prior the Omicron variant. Although we've seen record numbers of cases so far for this year in 2022, all-cause deaths do remain below the 2015 to 19 averages as seen on screen. Our vaccination drives continue to increase, and we've seen quite a significant increase in the 12 to 15-year-old second doses. And Chair, that concludes my slides. I have shared them for them to be distributed.
And they should be in members' inboxes, and I would encourage members to share them as widely on any council that they have links into, because I think it tells a very succinct story. So thank you for that, Emily. I think Anne Edgelow, did you wave at me that you wanted to?
Thank you, Chair. Really, I wasn't going to speak, but I've just visited some of the poorest poorest areas, I think, in the world, attached to the Commonwealth. And I found it very interesting that they take COVID very, very seriously. And you cannot enter a shop without having your hands sanitised. There's somebody there saying you've got, they won't let you enter. You've got to have your hands sanitised, and also wearing a mask as well. They won't let you enter a shop unless you wear a mask. So I find it very significant that you come back home and we can, just go into shops or anything. And I just wondered if there's any mileage in, trying to impress onto shop owners to have hand sanitisations as they enter the stores. Just a comment, Chair, and just wondered what the thoughts were from Emily and Richard. Thank you.
Thank you very much. The Living with COVID paper is very different to the previous Contain approach from central government, and it is more around personal responsibility and personal accountability. However, we are currently finalising the new local outbreak management plan that encompasses that new vision, but also includes how we and ourselves will support local businesses in helping the public make good choices. So I would echo your comments, and that's something we're considering and building into our new plan for 22 to 23, and how we'll go about supporting businesses to do that.
Thank you. Do we have any other further questions on this subject? Keith.
Just very quickly. It may have been covered in the presentation, apologies for that, but in terms of lateral flow tests and access to lateral flow test kits, Is there anything that you're planning to do to let people have their own responsibility in looking after themselves in the future and having that sort of almost inbred into the society that we now live in? I know it's a strange thing, but I think that would be the only positive thing that comes forward. It's a pity you haven't got flu tests and other things as well, and also a test for old geezers like me when you just turn around and say, I'm sorry, but you've only got a cough and cold, go back to work, as it were, you know. I'm being slightly facetious, but, you know, what are we going to be doing long term with COVID? And also, do you think the test kits will still keep working with all the variants that are coming up and will continue to come up for infinitum now? Thank you.
I think Keith's after the National Lottery numbers for the weekend, actually, based on one of those questions.
Well, I won't say I echo all of those comments. However, what I would say is that the lateral flow test, the intention is that the free public testing, so that lateral flow testing will cease. However, we are looking at our responsibilities around outbreak management. We're also looking at, as part of our review of the local outbreak management plan, we're looking at some of those additional communities that we may consider to be at risk for unilateral reasons and not just related to health, and how we might support them, especially when the free lateral flow offer ceases, and how that might impact. We're looking at completing a community impact assessment as part of that review so that we can really understand who will be affected by that choice and how we as an authority can support them. So that is a concern and something that we're very much thoughtful of and considering.
Julia.
Thank you very much.
Sorry, no, Julia Jessel, not Julie.
Oh.
Thank you very much, Chairman. I just wanted to add, and really in a little response to Councillor Edgela's comments about when you go abroad, it is quite marked. You go to different countries and they've still got restrictions in place. I think we shouldn't forget how successful our vaccination programme has been. And in effect, they've been the key to getting us back to some sort of freedom. It is personal responsibility, but to some sort of normality. And I'm sure with the reviews that are going to or are taking place, when assessing the effectiveness of some of the precautions, we will need to take into account the negative impacts that it's had on people's mental health, on the economy, and take a more balanced approach, because sometimes the cure has been worse than the original complaint. So I think it does show that the vaccination programme has been extremely successful. And I think we should continue as individuals, as I do, and the County Council as a whole, to keep getting that message out that you can still get your vaccinations and how important that is. I think with the graph that Emily displayed, it's that what I call middle-age group, the late 30s, early 40s, that probably think they're still, they don't need to be vaccinated, but it is extremely important. And we do need to keep reinforcing that message. But that's been the key that has unlocked us from 2 years of a very unique situation, which I hope we don't repeat. Thank you.
Julia, some really useful points. Keith, do you want to come back at all? I'm sure that was full and wholesome.
No, I didn't realise it was going to take so long. But no, thank you very much for all those. The one thing I would suggest, though, and I'm sure I'm teaching you to suck eggs on this, but obviously within the County Council we have a place-based approach and also some approach through schools as well. So if we do get stuck or there's an outbreak, then obviously you've got those two outlets that you can maybe start bringing in the lateral flow tests to help try and control any future outbreaks. I dare say I'm teaching you to suck eggs at the same time. Thank you.
I'm sure Keith, what actually Keith meant was the amount of things that you had to cover rather than that the answer went on for a long time. Emily, did you want to come back at all, or shall we go on to Julie?
No, that's fine.
Julie.
Thank you very much for that. It's very interesting. 2 questions, really. Is the 119 system still staying after April, or will that go? That's my first question. And I know we're all in this committee and in the borough and everywhere all in solidarity with Russia and the Ukraine. The people that are coming over, how will we know if they've been vaccinated or not? Because they're coming in the thousands. Is there any way we can find out whether, because we're on top of it, because our vaccination is fantastic, we've done a really good job, it's just bringing in the other people that are coming in now. How will we know if we stop free testing, how will we know whether we're bringing it in from that part of the world, which we... Thank you.
Can I suggest in answering that question you don't focus in on one specific strand of anyone coming into the country rather than on any strand of people coming into the country, please.
Mm-hmm.
Thank you. So 2 points. First of all was the question around 119. The 119 is a health number that's been provided. So I can't comment on how long they're intending to keep it. But what I can say is that we have our own COVID helpline that's on all of our material and communications, as well with our district partners that we've used and publicised. It's in all our plans and on the website. And that COVID number will remain and is staying and will be manned all the way through to March 2023. So I can provide that assurance. The second point around new entrants coming from abroad. So we previously dealt with this issue last year where we had some new entrants coming from a foreign national country. And as part of that process, we were able to implement quite a comprehensive plan to help those people enter safely, to help get them tested and also vaccinated if required. And so I have no concerns around any new entrants moving forward and us being able to repeat that exercise. We have the resources to do that. We've done it before. It's something we're familiar with, and I'm confident we can help keep any new entrants and our residents safe.
Thank you for that assurance, Julie.
Thank you very much, Chair. It wasn't the fact that I was trying to pick on one particular area. It's just the fact that we've got the issue that we've got. That was it. That was the only problem. Thank you very much.
Thank you. Let's move to a conclusion on that item. Can I make a couple of suggestions, however, committee? I think Emily's been brilliant over the last, I was going to say a couple of years now, isn't it? And I think we've probably got to a conclusion now that COVID is endemic in the environment. So I'm going to suggest that we don't voluntarily bring Emily back for a COVID update as the months go on, but we do thank her. And second of all, I'm going to suggest that we actually ask her that if there is any concerns that she's got, that she voluntarily brings it back to committee. I think we're all in agreement, Emily, so there you go. I think you have the seal of approval from the committee, and thank you for all the input over the last few months and years. It is appreciated.
Thank you all.
Number 8, we're nearly to a conclusion this afternoon. District and Borough Health Scrutiny updates. I notice there's been a whole rook of meetings after this meeting. I wonder who has got any updates that are not on the papers. Julie has. Julie.
Thank you, Sam. I'm going to have to read it to you. I can't remember what was said. This was taken, we had the committee on the 7th of March. Delivery of the new housing advice service, which was the committee considering the report on the service since it has returned in-house from April 2021. The benefits including access to joint housing register and housing advice, being available to the first point of contact of the council. Our services have managed with winter pressures. The committee considered the report on how frontline services had managed over the winter, including the additional pressures caused by Omicron variants and COVID. Members heard that in the first week of January, there was 30% among the recycling and waste workforce, alongside 50% increase managed to continue with the minimal disruption due to the usual suspension of garden waste collections and support with the street scene and agency staff. Space programme at its previous meeting On the 29th of November, the committee had received a presentation from Ben Adams, Police, Crime and Fire Commissioner, Dan Stafford, who outlined the key points of the police and invited to ask questions. One project mentioned by Mr Adams was the space programme held over the summer months and activity of the young people. Members considered the evaluation report and agreed a couple of questions to refer back to Mr Adams. Wally's Quarry impacts. The committee has been keeping a watch brief over the health impacts arising from outdoor odours. Members, made the following points. Concern about the unknown long physical impact on the health, the ongoing detrimental impact on mental health, concerned over whether hazardous waste is being dumped at Wally's Quarry, as raised by the local MP in Parliament, whether the posi shell capping was effective or was it disintegrating, impact on the watercourse, residents experiencing report fatigue and giving up reporting odours to the official channels. Members were also concerned about traffic issues on the site, the HEVs, queuing on the highway and difficulty of reporting obstructions via the 101 due to the long call wait times, and asked whether there would be police presence at the site. Members also asked whether the Director of Public Health is aware of any studies looking at a long-term impact of odours on health. Members also noted that supporting the permit variation could be seen as operations should be shut down and the permit withdrawn immediately. Meeting the clinical commissioning group, the committee received notes from the regular meeting between Chair and Vice Chair, officers and Tracy Shewan of the CCG. The meeting had discussed the current situation with COVID pressures and the Royal Stoke Hospital and the 111 online service. Reports from recent meetings of the police fire crime panel. Point 2, the digest outline of the work and recent meetings of the County Health and Care Overview Scrutiny. Point 3, and the final one, the work programme was discussed on the committee. Proposed items for the next meeting 23 of the 23rd of June were relating to dementia and safeguarding. Thank you.
Is there any other reports? Colin, I can see you indicating.
Yeah, just one quick one, Chair, really. You're aware of what's been going on in East Staffs. We took a report to Cabinet last night for engaging, supporting communities. It was well received, and I will get our Democratic Officer, Services Officer to supply members of the committee and this committee. Thank you.
Thank you. Really useful to share best practice as well, so thank you for that, Colin. Barbara.
Can I just say our meeting was taking place on the 9th of March. Unfortunately, it had to be postponed. The gentleman was ill, and it's now taking place on Thursday, the 17th of March.
Gives you a busy week. Okay, that's the work programme. Let me move off the work programme on to... Sorry, that brings me on to the work programme even. So, a couple of points on the work programme. Debs, do you want to handle this with Paul and Anne, or how do you want to do this?
If you take the lead, Chair, and Paul
Okay.
and Anne can chip in if they need to.
So we had scheduled a meeting for next week on the wider determinants of health. It was going to be a place-based review, and Anne is leading on that. However, we could do with the input of the new Director of new public health consultant who isn't recruited until April. So on that basis, we're going to propose to move that meeting back, which means that effectively you get some time back in your diaries for next Monday afternoon. Anne will be delighted because she'll make sure that the event is even more packed next time round without building expectation.
Definitely, Chairman.
The next scheduled meeting of this committee is Monday the 11th. We've reverted back to Mondays of April. And the principal objective of that meeting is to look at what the NHS and its various different bodies is doing in terms of climate change. If we look at climate change as an agenda, frankly, if we don't scrutinise what the NHS is doing on climate change, then we're missing one of the key roles that we have. So we will have a very dedicated but focused session, inviting in a number of the trusts to tell us what they're up to and how that integrates with their plans and planning for that area. I think on the basis there are a number of people who are interested in climate change. If there are other people who want to be involved in that discussion, then please do mention it to them just in case they want to be engaged and follow proceedings. Otherwise, we have two other elements. One relates to the
update on Cannock MIU from Marcus,
which will go into the next meeting in April, which will just be a quick sort of upfront discussion, and then
a care home update from Richard Harley. Thank you.
And then the only other update which is worth sharing at this moment is that work continues in terms of looking at best practice across Staffordshire on Staffordshire schools on mental health. Do you want to say anything, Paul?
Yes, thanks, Chair. Just to brief members, really, that we've had a few challenges in terms of getting everybody around the table. As you can see from the work programme in red, the Cabinet member has not been available, but one of the other main things that we were waiting was the mental health strategy report. We feel that needs to come forward before we put that in line with the children's mental health in schools. Without that, I think really we're doing it back to front. So that's why that's been put back to the 30th of May to facilitate the mental health strategy going forward. Thanks.
Thank you. Just on the mental health strategy, I'm aware that that has been put back and that has been actively worked on by a range of partners and the officers. And I think we would probably all welcome the opportunity to input into that when the timing is right. And I think the key point is at the moment the time isn't quite right. Keith Flander.
Just a quick follow-up on that. After the meeting on the 24th of Feb between various members of the committee, I was asked to work with Jonathan Price on some visits I'm doing to schools to give a report back to that same process. That meeting and the visit to a school in Biddulph will be happening next Monday, and I will bring a short report back, I hope, on what's been actually happening in schools. Thank you.
Thank you. I'm sure Paul appreciates that, as do the rest of the committee. Thank you. Anything else that people want to raise on in terms of work programme? I'm seeing no indications on that basis. Look forward. Phil.
Oh, my apologies. This may or may not be relevant, and it reminded me, we went along to a school in Cannock Chase with Jonathan Price, and there was a young lady there who was quite passionate about period poverty and the challenges it gives. So I've given her the opportunity it's a few weeks' time to come and present to Cannock councillors and a number of other people. I'm not sure whether you would like an outcome from that or whether we should report on that, especially being as it's Cannock. Would that be comfortable?
I think there are many members who would welcome seeing that and seeing the understanding the outcomes from that.
Okay,
and,
it's also worth noting the girl is 13 and at this stage fully prepared to talk to a number of councillors, so all credit to the young lady.
I'm sure you welcome that as well.
I'm sure we will. We may even give her a sandwich or two as well. Yeah. Right.
That is your choice. Okay, on that basis, thank you everyone for engagement this morning. Some interesting issues. We do need to make some progress on some of them, so I think we've made some hard-hitting recommendations. Thank you for input and take care. Enjoy the rest of your day. Bye.